and by histology. The primary endpoint is disease-free survival, which has not matured yet, and the secondary endpoints were overall survival, local, regional, systemic recurrence, and differences in the PFTs. I think it's almost a year now since we reported the first results, which are the perioperative mortality and morbidity results. These are important because I think they will set a standard of care, particularly for our when we have a discussion with our colleagues in competing technologies like SBRT. The trial registered more than 1,000 patients, randomized nearly 700. 357 to lobar resection and 340 to sublobar resection. And in this trial, where the participation was mainly from academic centers, 58% of the patients had a wedge resection. These are all patients that were required to have sampling of at least 2 mediastinal nodal stations and a major hilar nodal station, so we know that at least these were necessary for randomization. Like I said, the contribution from academic center was the largest portion, but there was a healthy representation from community centers. 20% of the patients were randomized from that group, and it speaks to the generalizability of the results. This is a comparison of the groups, and you can see they're evenly matched, or there is really no differences. I will draw your attention to this number here at the bottom. 80% of all the procedures in either arm were done minimally invasively. That is just remarkable, and I think speaks volumes about the quality of thoracic surgery across the nation, in Canada and in Australia. I think it should set a new standard for the care that we provide as thoracic surgeons. It is a shame that we did not have the foresight to include the length of stay in our case report forms 10 years ago. If we did, that would definitely be an important parameter. So here is the important number to keep in mind. In this multi-center nationwide Toronto, in the US and Canada and the US and Australia, the mortality for operations for early stage lung cancer is less than 1%, 0.86%. 1% for lobectomy and 0.6% for sublobar resection. These differences were not statistically significant between the groups, and as far as I'm concerned, these are excellent outcomes. At 90 days, the combined 90-day mortality was 1.4%, slightly higher for lobar resection than it is for sublobar resection, but yet not statistically significant. That's a number that we need to keep in mind. The recurrent refrain of lobectomy carries a 4 to 5% mortality is simply no longer true, and these are the data that would support that. What we've also learned is that mortality increases slightly by every decade of life. So you can see that in patients less than 60, it was 1% and 0 for sublobar resection, but it increases steadily in both arms of the trial. We had a few patients that were octogenarians. There was one death after lobectomy in an octogenarians and none after sublobar resection. And then if you exclude the octogenarians, the lobectomy mortality was 1.4%, sublobar resection was 1.2%. So these are excellent results and testament to the quality of care across all these, I think, almost 60 centers where the trial was conducted. What about adverse events? So serious adverse events occurred, grade 3 occurred in about 10% of the patients, and grade 4 about 3 to 4% of the patients. So you can say reliably that it's less than 15% regardless of the mode of resection. We looked at the predictors of adverse events, and the only predictors of adverse events were age and FEV1. Now we move on to the Japanese trial. The results of the Japanese trial were presented at an AATS meeting 2 years ago or 3 years ago, I can't quite recall. There are important differences between the two trials. The Japanese trial focused on patients with less than 2 centimeters as well that were node negative, but did not require a frozen section confirmation of the absence of nodal metastasis prior to randomization. So it was sufficient that the clinical stage was determined to be N0. Patients were then randomized to lobectomy. Their segment wedges were not allowed, and it was a non-inferiority design as well. These were the patient characteristics that were presented by Ken Suzuki at the AATS meeting, and the two groups are exactly the same. I will draw your attention to the fact that 10 to 12% of the patients had GGO-type lesions with a CT to tumor ratio of a consolidation to tumor ratio of less than 50%. They had since changed the protocol, but there was a small number of patients, really. All of them nearly had R0 resections. The mortality in these 1,100 patients was 0, none. That's an amazing accomplishment. And again, it's a number to keep in mind. Complications, slightly more blood loss after segmentectomy, nothing to write home about. And the frequency of reinsertion of the chest tube was essentially double after sublobar resection than it was after lobectomy. There's about 50% or more of the segmentectomies in this trial were, quote, complex segmentectomy. What does that mean? It means something other than a superior segmentectomy or a lingulectomy. Postoperative complications. The only difference between the two groups is that patients who had a segmentectomy had a higher incidence of air leak, roughly 10% versus 4% for the lobectomy group. That was statistically significant. This is just shows you that there was not an insignificant number of complex segments. What were the predictors of any mortality, any postoperative complication? I think the only one was pack year, smoking more than 20 pack year. But the predictors of early postoperative pulmonary complications were two. Complex segmentectomy was significantly associated with a higher incidence of early pulmonary complications. Now, the paper, I think, I want to say it was already published. Was it published? And one of the issues that that one can discuss further is whether you get any mileage out of a complex segmentectomy oncologically if you actually, in the return, buy a little bit higher pulmonary complication rate and perhaps a higher length of stay. So what are the important differences between the two? The JCOC trial allowed some part solid lesions to be included, provided the tumor to consolidation ratio was more than 50%. There was no requirement for intraoperative frozen section prior to randomization. And in our trial, we excluded ground glass lesions. We allowed segments or wedges because we wanted to make sure that our trial reflected real life. And as you can see, real life includes wedges about 2/3 of the time. The primary endpoint in our trial was disease-free survival versus overall survival. And here's an important difference. The Japanese trial was recruited 1,100 patients. The randomization was completed in 3 years as the investigators planned. We, on the other hand, had 1,100 patients in mind and had to, because of slow accrual, had to recalculate the sample size to 700 patients. And instead of 3, it took 10 years to accrue 700 patients, and we will require 7 years of follow-up. Today, we had a meeting of the investigators, the small meeting where we review the results. We have 249 events. The trigger is 352 events. So we're moving closer. My expectation is that hopefully within the next 1 or 2 years, we will be in a position to analyze data for the primary endpoint. And that's all I'm going to say. Thank you so much for your attention.
I think we have time for maybe one question. No? Okay. All right. We'll keep moving on then.
So I invite Dominique Gossot again to the podium to speak about sublobar resection, a surgeon's view.
Okay. I agree with you that the title of this presentation looks a little bit obscure. Shanda pushed me to put that title, but Shanda, I have changed it again. So what I will do this afternoon is not to give a real scientific talk about sublobar resections, but I will share with you my feeling about how it will radically change our practice, the practice of thoracic surgeons. I have some disclosure. I'm lecturer for Medtronic and Olympus company and consultant for manufacturer of instruments. So what is the situation in 2019? As you know, the population of the patients we are treating is changing. And I was amazed to see that in the United States in 2060, more than 90% of the population will be over 65. And if we look, so tumors are changing, we have more and more high-performance drug treatments, and alternative to surgical treatment is coming. So coming back to the change of the population, when we look at our own department, it's amazing to see how just in a couple of years, the age of our patients have raised. As you know, the tumors are changing, so we progressively move from these kind of tumors to this, and it will increase, of course, with the lung screening, the lung cancer screening programs. More and more competing modalities are coming. Even surgeons have an interest for these non-surgical treatments, as we saw yesterday, for instance, with Kelvin Lowe from London. And just an example among many others, in the Netherlands, half of the physicians consider that for stage 1 lung carcinoma, SBRT and surgery are equivalent. And of course, we as surgeons, it's something that is quite difficult to read. So are we prepared to these changes? When you look at these very recent papers that probably you have seen, you would say no. So probably Branton Stiles and Nasser will comment about this paper, but I was a little bit surprised to see that the patients who were screened obviously were a majority of stage 1, 73%, but only 5% underwent segmentectomy. This is in the US. And only 30% were operated by vets. I have put behind this slide another one that I have captured yesterday from Alan Chiu's presentation, just to show that it's very different according to the countries. So Alan Chiu in Hong Kong and China consider that lobectomy and thoracotomy is something from the past, and segmentectomy and minimally invasive surgery is something for the present. So in 2019, what patients and doctors want, they want more and more minimally invasive treatments, but with similar chances for survival and for cure. So the question is, which minimally invasive treatment will emerge? So we want to defend surgeons, but I think we need to look at what we are doing. So what are the strengths of surgery? Surgery removes the whole tumor with adequate safety margins. With additional lymph node dissection, we can perform extensive dissection of the lymph nodes. And so far, according to all studies, it gives the best survival. On the other hand, we have some weaknesses among mortality and morbidity. So this is the study you probably know from 2014, extracted from the National Cancer Database, showing a mortality of 2.6% for standard lobectomy. So Nasser has just told us that In the trial, it's 1.6. It's better, but it's not nothing. To say that if tomorrow you have a lobectomy, you have 1.6% chance of dying from the operation. So I was interested last year to hear Keith Nolan saying that people don't want surgery anymore. Maybe it's a little bit exaggerated, but we have to take this into consideration. This means that if we, as surgeons, we trust surgery as the most efficient and most logical treatment. I say logical because it's logic to remove the tumor rather than firing on the tumor with SBRT or giving drugs. If we want to be of benefit to our patients and if we want to remain competitive with other treatments, we have to find the best compromise between lobectomy and non-surgical options. So today, there are more and more data that shows that segmentectomies are equivalent to lobectomies, at least for survival. And there are many data that shows that if you want to perform a segmentectomy, it should be done by vets. All the benefit from segmentectomy is better if you don't open the chest. This is on the left side, a study we had published a couple of years ago showing that the thoracoscopic approach was really much better than thoracotomy. And there are many other publications that have chosen this one because Nasser is co-author of it, showing the same thing. So our concern is that segmentectomies should be done by vets, but everyone in this room will agree that it's a true challenge. I give you just some example. In 2019, we will not consider that this pulmonary sequestration should have a lobectomy as we did a couple of years ago. We will try to remove only the pathological lung, which is segment 9 and 10. And even those in this audience who are performing segmentectomy 9 plus 10 know that it's quite difficult. This typical carcinoid tumor, if you follow the guidelines, what say the guidelines? The guidelines say you have to perform an anatomical resection as small as possible. So this tumor is in segment 8. Again, you have to perform a segment 8, which is not, it's not very, very difficult, but it's not obvious. And in this patient who has 2 metastases from colonic carcinoma, everyone, I think, can perform a segment 6, but on the right side, this requires a segment 9 plus 10. Again, this is not an easy operation. So this challenge means that, why do I write that we must remain humble? We must remain humble because even in the high-volume centers, like we are for segmentectomies, so this is our experience, so every year it increases, every day we learn something more, and we consider that there is no learning curve for segmentectomy. So this raises the issue of high-volume centers. So according to the recommendations, VATS lobectomies should be done in expert centers. I don't know exactly what it is, but it is written like this in the guidelines. So what about segmentectomies? Should they be done in expert centers? I don't know. And we must consider any technological mean that can help. This means that we have to switch to a technology-driven surgery. By this, I mean that we must use preoperative planning, intraoperative mapping, target localization, any technological mean to identify the intersegmental plane and divide this plane. So this is what we are using routinely in the department. Okay, I will try to. Okay. So I come to my conclusion. Okay. So the rate of early-stage lung carcinoma is rising, as you know. and we consider in this room that surgery is the best option. So, but we have to reduce its morbidity while being as oncological as other treatments. How to reduce the morbidity of what we are doing? I think that requires enhancing the precision of what we are doing, not only indication, but in the technique. So if we have a patient, we wonder whether we should perform a lobectomy or a segmentectomy. We are not quite sure. Today, in 2019, we have to ask for a modelization. If we are not sure, you can also perform, Shanda probably will ask for a 3D printing and move to a lobectomy. On the other hand, if we are sure that we will perform a sublobar resection, we will need a way to localize the target, check the anatomy before the operation. This requires a preoperative modelization or 3D printing. Have a mean to identify the intersegmental plane. Have another mean to check the lymph node during the procedure by a frozen section on the lymph nodes, and same on the margin, and we have to anticipate the safety margins. So this evolution does not appear in this paper, and the question is why? Do we consider that it takes too much time, or that it's too much expensive, or that it's too complex? If you think this, I think you have to sit and think about what we are doing. And this is, I think, illustrated by this line drawing. Sometimes you have to add some complexity to make things simple and safer. Thank you very much, and sorry for taking too much time.
I think in the interest of time, we move forward. And the next speaker is Brendan Stiles, and he will talk about what are the requirements for an oncologically sound sublobar resection.
Well, it's certainly a daunting task to tell this group what's oncologically sound for anything, but so thank you for offering for me to give this talk, and thanks to the moderators. These are my disclosures. Why does it matter? I think Dr. Gassot just laid out that exactly why. Regardless of the randomized trials that are ongoing, sublobar resection is clearly here to stay. Other competitors in the treatment landscape are lung preserving, and so we need to be too, whether that's SBRT or ablative technologies, which we've heard all about. But we all think and believe, I think, that a surgeon's ability to accurately stage and provide optimal local control should ensure that surgery is the ideal option for most of these patients. But there's been an increased focus on both perioperative outcomes in the public and on patient-reported outcomes that mandate that we perform a sublobar resection, not only oncologically, but also safely, expeditiously, with minimal time in the hospital and minimal pain. So I tend to think of two main sets of factors that affect sublobar resection. On the one hand, there's tumor factors, and that's size, location, radiologic features, and histologic subtype. And on the other side, there's surgeon factors, certainly. Are we good stagers? Are we good at getting surgical margins? Do we do a lymph node dissection? And maybe what type of sublobar resection we perform. I'm going to go through each of those briefly. So starting with tumors and size, I think the randomized trials clearly just include patients to a size limit of 2 centimeters. We know that larger tumors have higher rates of nodal metastases. We know it's more challenging to get adequate margins. I think our group has written this quite some time ago now, but the inaccuracy of clinical stage, and we all know to be true. In this study on clinical stage 1 tumors, we had 35% of patients were understaged. And you can see greater than 2 centimeters, that was 50-50, essentially a coin toss for pathologic stage 1A. And 30% of those patients were upstaged to stage 2. Maybe at Cornell we're just bad at staging, but there was also a study by Dr. Lick showing similar results. For T1N0, the accuracy was 56%, but the rate of upstaging to nodal or metastatic disease was only 13%. But for T2 tumors, it increases dramatically, it doubles. So we know that tumor size is important. What the actual cutoff for that is less well defined. In the past, there's this sort of classic meta-analysis from Dr. Nakamura talking about the effect of sublobar resection on survival, and it's amplified with larger tumors. We know that with small tumors, a lot of these collective studies of retrospective data can show that you can get equivalence between segmentectomy and lobectomy. But as we go up with larger tumors, we start to lose that ability and that equivalence. This is a study that we had presented at the ESTS a couple of years ago that clearly shows that with larger tumor increments, 2 to 3 centimeters, 3 to 4 centimeters, 4 to 5 centimeters, that sublobar resection is an inferior procedure compared to lobectomy. What about radiologic features? Obviously, the lion's share of the work has been done in Japan. JCOG 0201 showed that radiographic non-invasive adenocarcinoma was an entity, and particularly for tumors, again, less than 2 centimeters and less than a 0.25 consolidation to maximum tumor diameter ratio. These patients had an overall survival of over 95%, which is pretty remarkable, and obviously argues that lung-preserving therapy may be and should perhaps be the standard of care there. If you look at the clinical trial that they had performed in that setting, JCOG 0804, there was a 99% 5-year recurrence-free survival in those tumors when allocated to limited resection. Perhaps even bigger, and the group's, lots of work from Dr. Hattori and others have even pushed this up to the idea that the tumor consolidation ratio less than 0.5 is probably still fine. These patients have survival over 95%. And even any GGO component may portend a better prognosis. If you look stage for stage in the T staging, solid component versus part solid, we're going to do better with the part solid tumors. A compelling body of work, again, suggesting that radiologic features can guide us towards when a tumor is going to be more invasive. Well, how about PET scan? Can we further utilize PET scan to segregate these tumors? And this is work from the Sloan Kettering group, Dr. Nita Dorian. So they looked at that tumor to consolidation ratio of 0.25 and further segregated by PET. You can see the blue line at the bottom. If they had less than 0.25% solid, there were no recurrences. But with limited resection and a higher PET, there was a higher recurrence. And they used a cutoff of 2.2. And you can pick your number from the literature. Lots have written about other PET SUVs that are predictive, but certainly a higher PET SUV should perhaps cause one to pause. Our own group has written on this and particularly thought about how it would relate to tumor size. Is it really just an absolute PET cutoff, or is it related to the tumor size? I personally would be more comfortable doing a limited resection on a 3-centimeter tumor with an SUV of 4 than on a 1-centimeter tumor with an SUV of 4. So that's something that I try to think about as I go. We had shown that there's a 30% risk of lymph node metastasis in that high quartile of SUV to tumor size ratio compared to 6% in the lowest quartile. What else about the tumor? Histology. And the Memorial Group has led the way with this a lot, and Prasad Adesmili and Bill Travis. First, the concept of micropapillary component. Yes, it's hard to figure out. It's hard to sort of put a specific number and percent to it. But clearly in their data, there was a much higher rate of recurrence with micropapillary histology with limited resection. Whether that applies to all micropapillary tumors and the effect of the margin on that is still debatable, but clearly micropapillary tumors have a higher risk of recurrence with limited resection. This is what their recurrence curves look like, their 5-year cumulative incidence of recurrence with limited resection versus lobectomy, depending upon the percentage of micropapillary tumor. And then there's, of course, STAS, and I know hotly debated. I think Nasser gets mad at me every time I say the word STAS. But clearly, the Memorial Group at least has defined this entity of STAS, and others have started to do so as well, suggesting that it too is a risk factor for local regional recurrence after limited resection. The challenge, obviously, with both, and I should say it's been validated by others, and Dr. Shiono in the room and other series have also shown that STAS is a predictor, particularly with limited resection. The real question is, can this be evaluated preoperatively? Is there any way to find this out and to guide your resection before you do it? Is it something that you find after? If you find STAS with a close margin after resection, should you go back and do a lobectomy? Those questions still remain to be answered. And then, of course, the surgeon matters too. Right? We all know that. I think influencing and helping the public to understand why that's important is also critical. But before we go to the OR, part of our job as surgeons, and I think where we do better than a lot of other specialties, is to stage the patient well. I know across the world it's perhaps different. In the US, I'm still surprised that the value of PET scan is debated. I know that there's lots of studies that show it may not be cost effective, but clearly we know that PET scan is better than CT scan at identifying nodal metastases. It's better at identifying distant disease from ACOZOG Z50. And in that study that I mentioned previously on bigger tumors, when I looked at the data closely and when we sort of sorted through it, this is a National Cancer Database study on pathologic N0 after sublobar resection. One of the strongest predictors of outcome was getting a preoperative PET reduced your chance of death or dying or recurrence by 30%. Again, suggesting if we stage the patients well before we take them to the operating room and make that decision to do a sublobar resection, they're going to do better. And then, of course, in the OR, the surgical margin matters. And this is work that was really led by some of the seminal series from Pittsburgh and Matt Schuchert and others. And margin, again, is sort of ill-defined. Is it an absolute margin? Is it a tumor size to margin ratio? The group here had described, and you can see quite nicely that they did the margin to the tumor size ratio, and this is all their recurrences. And you can see generally the recurrences were in the group that had a margin to tumor size ratio less than 1. And I think that a lot of people think through that sort of same thinking when they undertake limited resection, particularly for bigger tumors. If you look through the literature, there's lots of studies that talk about margin. In general, the cutoff typically used and analyzed is 1 centimeter, and you can see only one study was there no difference. The others all show doubling, even more risk of local recurrence if the margin is close. How that relates to pathologic subfactors has still not been well determined, and one would think that it must. And the other question is, does it matter for part solid tumors or for GGOs? Do you need to get a 1 centimeter margin? I certainly don't know the answer to that. We have data from our own institution that suggests for pure GGOs, one may not have to get any more than a couple millimeters margin. I'm not sure that's been well defined. And then finally, of course, lymph nodes. We all talk about it, we all know about it. A lot of our studies show that we don't do lymph nodes well, even when we put them in the larger studies. This is from Sayenda Murray's group, though. A SEER study, sublobar resection, less than 2 centimeters, stage 1 non-small cell lung cancer. He found a survival benefit for each node number category, going up. The more nodes that you took with sublobar resection, the better the patients did. The overall survival curves are on the top. If you didn't do nodes, you did worse. The disease-specific survival curve is on the bottom. Again, with each subset of nodes, one did better. We had followed that up with a SEER Medicare study that showed that yes, patients do worse with sublobar resection compared to lobectomy, but if we took the subset of the patients who had sublobar resection and a good lymphadenectomy, then they would do well. And I'm coming to the end. And then the surgical procedure, I don't know. We know that we do less with less nodes and less margin with wedge resection, but we still do it. Our group had shown that we had no difference in segmentectomy versus wedge at Cornell. I think the answer is still out there. And that's all I have.
Thank you. So before we bring up our next speaker, or as he's setting up, can everyone in the back row please come sit in the front row? We have plenty of chairs, and it's just killing me to watch you guys stand. Can we take a second? Can you come sit down, make yourself comfortable, settle in? I won't make the announcement for the next speaker until everyone's seated. All right, so our next speaker is Dr. Brunelli from St. James Hospital, and he'll be speaking on cardiorespiratory function and SLC. Can we lower the limit?
How do you go out? What? How do you move it?
I think you just, you can dial up and down.
Doesn't work. Doesn't work.
The mouse is not working.
Oh, the arrow key. Yeah, but
Use the arrow keys to advance.
here.
Yeah, it's not working.
It's not working.
I just pushed it.
Sorry.
This seems like a good moment for everyone to stand up and do Bronco Taiso.
But it must be me. I lost the flight, connection.
Oh, really?
It's not a good.
Just in time.
Just Alex, you know that it's broadcasted on CTSNet.
Okay.
Go ahead.
Let's go back to science. So, first of all, thank you very much. I thank the organizer for inviting me, and I'll talk about pulmonary function and cardiorespiratory function in conjunction with sublobar resection. So first of all, this is the last figures in the European registry, in the STS database, and there are approximately 8,000 segmentectomies corresponding to 10% of the anatomic resection for cancer, which is not a negligible number. When we stratify the patient in classes of risk using the Eurolung and consider the patient with the highest class of risk, the comparison between predicted and observed mortality rate, you see, is basically the same for lobectomy, 4%, but segmentectomies appear protective in terms of risk of death. And this is the highest category of risk. The same when we compare the absolute 30-day mortality in the highest class of risk in the ESTS database, you see how there is an incremental 30-day mortality rate by extent of resection, and the segments have 1.8% mortality rate compared to lobectomy 2.9. Again, we were discussing before that segmentectomy must be performed whenever possible by minimal invasive surgery, and this is a demonstration in real life that in the European registry, those performed by minimal invasive surgery have a mortality rate of 0.5%, but those performed open have a mortality rate threefold higher. Unfortunately, only 37% of segmentectomies in Europe, or I would say in the European database, are performed by VATS or rats. And this leads to the ACCP guidelines recommendation that in patients deemed unfit for lobectomy, a sublobar resection, anatomic sublobar resection over a lobectomy is suggested. However, when considering compromised segmentectomy, those performed for poor cardiopulmonary function or comorbidities, the long-term prognosis compared to lobectomy is poorer. So when we compare lobectomy and segmentectomies, we always need to distinguish between intentional and compromised segmentectomy. How is the evolution of pulmonary function after segmentectomy compared to lobectomy? This is a nice systematic review showing that the functional loss in terms of a FEV1 after segmentectomy is less, not just at a year, but even yearly after surgery, which is important when considering prevention of complication. For instance, in this study, including many wedges, not only segmentectomies, the pre-post-op ratio of the FEV1 and the LCO after segmentectomy or sublobar resection is much lower, so the preservation or the loss is lower, and the preservation is higher, both for a FEV1 and the LCO, either at 3 months and 12 months. So basically, after a year, after a sublobar resection, a VATS sublobar resection, the FEV1 loss is only 2%, and the LCO loss is less than 1%. And in this other study, performing a VATS sublobar resection was one of the significant predictive factors associated with a preserved FEV1 or the LCO, or FEV1 and the LCO together. So how it works? So how does it function? What happened after a segmentectomy in comparison of lobectomy in terms of modification and changes of pulmonary function? And you see here, this is a paper in Press in the Annals, that overall the postoperative pulmonary function is about 92% compared to pre-op after a segmentectomy. This is 6 months after surgery, compared to 82% after lobectomy. And this is due mainly to an increase or an expansion or increase in function of the unaffected lobe on the same side, which in comparison with the preserved residual volume of the operated lobe makes obviously a better preservation of the pulmonary function. The number of segments count. Sometimes we tend to bundle all together segmentectomies, but there is segmentectomy and segmentectomy, single segmentectomy, more than one segment, and you see how this affects the preservation of pulmonary function, which is much higher, obviously, with single segmentectomies, and especially the residual lobe function is, as expected, lower when we do more than one segment. While the compensation from the unaffected residual lobe from the same side is higher when we perform more than one segment. We resect more than one segment. There is no difference between typical and atypical segmentectomy in terms of preservation of pulmonary function in this study. Again, this other interesting paper is comparing or taking into consideration more than 100 open segmentectomy, so performed through thoracotomy. And they obviously compared single segmentectomy with segmentectomy including more than one segment, concluding that basically when you do a left upper division, the residual pulmonary function is similar to a left upper lobectomy. So there is not much difference in terms of pulmonary preservation. And you see here, this is the function of the preserved lobe on the same side, which is quite low after a left upper division compared to reduced number of segments. When considering case-matched comparison in VATS cases, here VATS segmentectomies versus VATS lobectomies at 6 months, the site of segmentectomy, it doesn't affect the residual function except for the left lower lobe. Even after the left lower lobectomy, the residual function is quite good, 90%. So for this reason, there is no difference between segmentectomy and lobectomy. And this is the comparison of the pre-op, post-op FEV1 of the contralateral lung. And there is no difference between segmentectomy and lobectomy in the increase of the contralateral lung function, which occurred to compensate the removal of a segment or a lobe. On the other hand, regarding the ipsilateral non-affected lobe, this seems to increase in function only after segmentectomy, but not after lobectomy. So this is basically what happens, the diagram of what happened after segmentectomy and lobectomy in terms of a compensatory increase of function of the residual lobes and the contralateral lung. Typical and atypical segmentectomy, typical meaning superior segment, lingular and upper division. All the rest is considered atypical. There is no difference in terms of preservation of function, even when considering more than one segment between the two. So in conclusion, compared to lobectomy, segmentectomy is associated with a reduced mortality, especially in high-risk patients. Minimal invasive approach should be used whenever possible to enhance the benefits of sublobar resection. And compared to lobectomy, early and late postoperative pulmonary functions are more preserved, especially in case of single segmentectomy. However, when chosen as compromised operation, the long-term survival is worse compared to lobectomy. So I like to conclude with the conclusion of the paper that we have discussed before, that given the fact that the preservation of pulmonary function is better after segmentectomy compared to lobectomy, if a non-inferiority in overall survival will be confirmed, then segmentectomy should become the operation of standard operation. Thank you very much. Discussion?
Maybe
Yes,
time
time,
for
sir.
one quick question. I think we're almost over time. I have that this next session starts at 2:50. Yeah?
Can I ask a question? Just to the whole panel, is that okay? Just a very quick question. I mean, a lot of good points have been made today, and one of them, most important point, was patients want a minimally invasive operation with less lung resection without any increased risk of cancer, and that's a common premise. But can I ask if everyone is, and I don't know the answer, so this is a genuine question, I have no agenda. Is everyone kind of like predicting the results of the 2 trials before they even are released? So what if both JCOG 0802 and the Alliance Group trial show that it's not equivalent, and in fact the cancer risk is higher? I mean, what would patients want? If it comes down to it, which is more important to you, losing a bit more lung function or getting your cancer back early? And whilst we are prejudging what the results are going to be, everyone is moving towards lesser resection, especially when Brendan's study also showed that even if you do it today, the sublobar had higher recurrence rates and mortality. So how does all this figure?
I think this is a question to ask the patients when we'll have the results, and especially the results of quality of life, not just the results in terms of survival. It's the usual dilemma that we face every day nowadays in the evoluted patients, in the shared decision-making process, taking into account everything. So not just complication or mortality, but cancer cure, but also quality of life. Some patients just decide to perhaps live shorter, but with a good quality of life. But also all depends on the balance between these factors. And in fact, you're right. We need to wait until the results are out.
Yeah, I think for stage 1 lung cancer, we don't know exactly what's correct, but we do know for multifocal lung cancer and patients who have typical carcinoids or other types of resections, it's appropriate now. And whether or not it'll be appropriate for your typical stage 1 patient, that remains to be seen.
We all say that, but LCSG 821 showed that lobectomy had better, lower recurrence rates.
Yeah.
But yet we all say that, well, we don't want to listen to that, or we don't care about that anymore. We're just going to repeat it with 2 centimeters instead of 3 centimeters, because that data certainly doesn't apply anymore. So I also don't really quite get my head around that as well.
Yeah, I think you have to be really careful about just changing your mind without data. Okay, all right, we'll just change moderators. Renee, are you the next one? Later.
Okay, so we start the second session. It's more intraoperative technical points, and I'm glad to invite Herbert de Calway from Belgium to give the first talk on intersegmental plane identification. Just 5 minutes.
How it works?
That's okay.
Good morning and good afternoon. Thank you again for the invitation. I'll talk about identification of segmental fissure by insufflation technique. And so how does it work? Yeah, okay. So my only disclosure is that I don't like to use this technique anymore. And so I use the technique of the next speaker, the Industrial green technique with infrared. But when it's available, I mean, when I use a robot, it's standard. And when I have access to the infrared camera, I can use it. So you can call this the poor man's technique. What you need is an infusion line, a 3-way valve, CO2, a syringe of 50 cc, And I'm just going to show you a video of some segmentectomies. It's an old video. And it really helped me some years ago to understand the anatomy of the segments. At that time, we used the 3-port anterior technique. And after the opening of the fissure, so we use a needle to puncture the bronchus. Now, it's very important that you transect the artery and, importantly, also the vein before you use this technique. But as you can imagine, you could puncture the vein and cause an emboli. So that's also the reason why we use CO2. If you would cause an embolus with CO2, this is less severe or dangerous than if you would use normal oxygen. The other problem with this technique is that you have cross-ventilation. So I'm only showing the good videos, of course, and we had some, I mean, like in 30% of the cases, you have severe cross-ventilation, and this technique is not helping you. The other way to do it is that you would ventilate the complete remaining lung, but then you obscure your view, and that I really don't like. So that's why we use this technique, if you cannot use the Indocin green, where you can really ventilate with CO2 the part that you're going to resect. And so you create a demarcation line, and then with staplers you transect the remaining segments. That's right. So you can correct here, we see the line, and you push down the parenchyma. Another example of left segment 6. And there we had a problem because we went into the subsegments with our staple line, and so we chose the subsegment to puncture, and you'll see that only the basal part of segment 6 is recruited. But that's what you need, the line between segment 6 and the other segments, or the basal segments. When you transect the parenchyma for segmentectomy, it's really important that you pull out the hilar structures of that segment. So what I like to do is to grasp the bronchus and to make sure that that's not in your staple line. That's really important. Otherwise, it can become a bit messy. I also like to use black cartridges for segmentectomies. Finally, I think a lingulectomy. We like to use a fissure first technique, especially for segmental resections. We open the fissure first with staplers, even when the fissure is not well developed. So this technique, I mean, I've done it in many patients, and in the beginning it really helped me to understand anatomy. Now, if I can, I use Indocin green. But of course, you're doing an oncologic resection, so the idea is that you try to take as much of the parenchyma as possible to have a good margin. So you don't always need it. Here again, holding the bronchus to take that structure out of your staple line, and be careful for the remaining vein there. We're just in the right spot, I think. So that's the video. So, a caution, there are some abstracts or papers on severe emboli. So you should not do this without transecting artery and veins, and you should use CO2. That's it. Thank you very much.
Thanks. No questions. We will have the discussion at the end, so I'm glad to call Dominique And that's the right place to thank him for the second edition of the Sublobar Conference and for his input in the department. So, Indocyan in green.
It's blue for the moment.
Can we have the slides of Dominic, please?
So, as you know, the intersegmental plane is sometimes the most challenging part of these operations. Here are several techniques that you can use: inflation, deflation, catheterization of the segmental bronchus, tattooing or marking with methylene blue through ENB. And I don't know if Masaki Sato is in this room, but of course the wall map technique. Finally, I come directly to the near-infrared imaging system. So the way it works is that you inject, for those who are not very familiar with this, you inject indocyanine intravenously. It links with the protein of the plasma, and if you emit an infrared light, it gives a green fluorescence. So to show you how accurate it is, this is a line drawing from an article from Shanda Blackman about a segment 10. I don't have the same segment 10, but I have 9 plus 10. And you see that it's almost the same. It's, the lines are very sharp. The results are very good in most papers, although the series are not very important, but the success rate is around 90%. So why 10% failure? It's usually observed in COPD patients and patients with emphysema, probably because the vascularization of the lung in this patient is poor. There are no complications reported. Theoretically, there can be hepatic insufficiency because the product is eliminated by the liver, but I think that practically it's not observed. So here are a few examples. You see the staple line on a segmentectomy 1+2 on the right side. Here for segment 6 or a basilar segmentectomy. If you don't have the chance to have a preoperative modelization and you are hesitating sometime which artery should be divided, you can make a test with indocyanine green by temporarily clamping the artery and then inject ICG. It helps a lot for the direction of the intersegmental plane. For instance, this is a lingulectomy. What you see, the marking is something we made with the special clamp we apply on the parenchyma before firing the stapler. So this is the supposed direction, that one. And of course, after injection of indocyanine, the correct direction is that one. Same on segment 6. It's theoretically very easy. So you see the direction of the clamp. And after indocyanine green, it's that one. So sometimes there are failures. I show you 2 examples. So here it's for segmentectomy 9 plus 10. So you see that segment 8 is red. Segment 8 is green. Segment 6 is green, and there is this stripe which is not green, and you don't understand why. And if you look at what happens during the operation, you see that the artery A8 is normal, A6 is okay, but there was a clip on a small branch of segment 8 that explained why this stripe was not green. And maybe you have seen this video on CTSNet. So this is a basilar segmentectomy. As you see on the picture, the anatomy is extremely clear, no problem. We divide the basilar arterial trunk and inject the indocyanine just to have the line between segment 6 and the basilar segments. And actually, this is what happened. So it's not sharp at all. And we have the surprise to see that segment 10 was green, and the reason is that there was an accessory branch coming from segment 6 to the basilar segment. Other potential indications are localization of nodules. I will not comment on this because I don't want to be out of my time twice. So it's not the perfect tool, but almost. And I just give you a complication for the surgeon, a complication of using too much indocyanine. This is something that happened to me. A couple of weeks ago, I was at the airport, went to wash my hands, put my hands in the drying machine, and I had the surprise to see that it turned green. I don't know if you have an explanation. Okay, thank you very much.
Okay, next speaker will be Dr. Chida, presenting the division of the intersegmental brain. So please keep the time. It's
okay.
5 minutes.
Just a moment. Okay. Okay. To divide the intersegmental brain, so to staple or not to staple, that is the question. The merit of the stapling is speedy and less air leakage, and demerit is lung may not expand fully. And candidate is diseased lung is normal lung. For in Japan, still energy device are used. It is popular to use the energy device to divide the intersegmental brain. So I show the videos. 55-year-old male underwent left upper trisegmentectomy, is 1 to 3, for invasive adenocarcinoma. So after, so when we make the intersegmental brain, so V3, we divide along the V3 BC. This is just the peripheral side, but then we make the IS intersegmental brain along the V3 BC. So intersegmental vein remains in the lingular side. So just using electric cautery to divide the intersegmental brain. We can find the intersegmental vein along the intersegmental plane along the intersegmental vein. So finally, so we divide the segment. Then we need to check the air leak. So we have often this explains the air leakage. In this case, there is a injured bronchus, so we need to repair the bronchus. So to avoid the stenosis, so just make the horizontal mattress suture. After the repair of the bronchus, so there is no air leakage. Huh? Yeah, just is the bubble of the water. No air leakage.
Okay.
Yeah, so when we, the intersegmental vein of V3BC remains, so the upper side will segment 4 has a lung function because the oxidized blood flow back to the heart. And then we put the PGA sheet covering the intersegment plane to protect the air leakage from the alveolus. So PGA sheets were covered with fabric glue. Okay, so summary, so dividing the intersegmental plane using electrocautery may result in air leakage. I think that is why the JCOG study, we have a lot of prolonged air leakage in segmentectomy. So careful repairs of ISP are mandatory to avoid the prolonged air leakage, such as bronchial fissuras. Covering ISP with artificial pleura using PGA sheet is an option. Thank you.
So we have no time, so we have to move to the next speaker. Next speaker will be Dr. Sato from Tokyo, Japan, and his talk will be the intersegmental vein.
Okay, thank you very much for giving me such an important topic. So this is a famous textbook from written by Dr. Nomori and Dr. Okada. I had the Japanese version of this book, but for my presentation, I purchased the English version as well. So this is really an excellent textbook if you want to learn segmentectomy. So the pure segmentectomy is something like this, as I show here. So anatomically, the segment is separated by intersegmental veins. And if you want to do a true anatomical segmentectomy, you have to pick up the bronchus, as I show here, and then dissect the intersegmental plane, leaving the intersegmental vein, as I show here. So here's a more complex segmentectomy of S6 plus S8A, but basically the same thing. Intersegmental or intersubsegmental vein is left behind, as I show here, as B8A. But of course, if you use electrocautery, as Professor Chida showed, there's a high risk of air leakage. So that's a kind of trade-off. So to prevent that, we very often use stapler, and I never do segmentectomy using electrocautery because of my previous bad experience. So I always use stapler 100%. But even if I do segmentectomy with a stapler, I dissect the hilar structure very carefully using electrocautery. It doesn't cause so much air leak, and identify intersegmental vein. That's really the key, I think, to do a segmentectomy. So if you use stapler, it's not a true anatomical segmentectomy, but rather it's a pseudo-anatomical or semi-anatomical segmentectomy. But the question is, if we need true anatomical segmentectomy all the time, if the lesion is pure ground glass nodule or a metastatic tumor, we would do wedge resection if they were located peripherally rather than centrally. So in such a case, very often we just cut the bronchus and artery and pick up the lung to make more margin, and then just staple out, kind of ignoring the pulmonary vein. The other important issue is the lymphatics. So as you know, lymph flow goes around the pulmonary vein, including intersegmental pulmonary vein. So we cannot ignore the truth if we do oncological surgery. So the question is, if we should really leave intersegmental plane, intersegmental vein, if the tumor is located relatively close to the vein. In other words, the vein could be a drainage vein from the tumor. So in such a case, I tend to cut the pulmonary vein in the line A instead of line B. then the next problem is that could cause a congestion in the adjacent segment or subsegment. So if it causes severe congestion in the adjacent segment, I would take the adjacent segment out as well because the congestion is very bad for the patient. So this kind of consideration could be done before surgery. That's why we think that the 3D modeling is really important. Preparation is really important for segmentectomy. So I believe that there are three most important things in segmentectomy: preparation, and preparation. Okay, thank you very much for your attention, and I'm looking forward to seeing you in the 3rd International Conference in Tokyo next year.
We just have time for 1 or 2 questions, quick ones.
Eric Lim again. The speakers have very eloquently illustrated 3 methods of defining a segment. You can use via bronchial inflation, or you can use via intersinus green through arterial differentiation, or you can use the veins via anatomical venous differentiation. How do the 3 methods actually concur? And if you were to use a stapler, the anatomical segment is a 3-dimensional structure, and a staple line essentially is one 2-dimensional line. And how does that affect the actual cancer clearance?
Actually, that's a great question. So the 2 methods, like inflation deflation line or using ICG, they basically delineate the intersegmental plane at the peripheral side of the lung. Intersegmental vein, that delineate the intersegmental plane at the hilum, but it separates and it's a line, so it's not a plane. So by definition, it cannot really tell you the whole intersegmental plane just by tracking the pulmonary vein. That's my understanding. So basically, the line between, or the plane between the bottom of the intersegmental vein and the peripheral lines we delineate either by inflation, deflation, or ICG, or whatever. That's a intersegmental plane we should cut in. And when we use stapler, that's a kind of crashing the two-dimensional plane into one line. So that's a trick, and that's actually what the problem happens. Sometimes the line involves more parenchyma that should be left behind, or that should be cut. Then that line could not be that accurate as we think.
Hi, outstanding session is Ghulam Abbas. I just had a quick comment and question for my US colleagues who do segmentectomy. One of the papers, they showed that out of 70% of stage 1 lung cancer, only 5% had segmentectomy. We talk about techniques, we don't talk about the economy of segmentectomy in US. As a thoracic surgeon, if you do a open lobectomy or a segmentectomy, like 328480 is the CPT code, you get paid much higher. And the DRG of all the lobectomy or segmentectomy, Medicare pays the US hospital is 163, 164, 165, is the same payment. So when you do a lobectomy, you're using 3 or 4 less stapler, which is $1,000, plus you use a glue or something, which is another, if you use a Progel, is $900. And if your length of stay is more, it's $1,500 per day per segmentectomy. So your hospital takes a hit. And for surgeons who work for RVU, when you do a segmentectomy, you get 23 RVUs. And when you do a lobectomy, you get 26 RVUs. We don't pay attention to that. Now, if you do 2 segmentectomies, I was just notified, surprisingly, that you cannot bill for 2 segmentectomy. The Medicare or the surgeon, as a surgeon, you get a RVU for 1 segmentectomy. On the other end, if you do a wedge resection, is CPT code 32668, you get 15 RVUs, plus every other wedge resection, you get 3 or 4 RVUs. So if you do a segmentectomy and a wedge, you cannot bill for it. You can only bill for a segmentectomy. So at the end of the day, when you see, I'm not saying that's one of the reasons. I believe on segmentectomy, 50% of our lung resections are segmentectomy. But if you look at the surgeon fee and the hospital income, segmentectomy is economically worse for the hospital and surgeon as compared to doing a lobectomy. And for surgeon, it's better to do a thoracotomy because that's what is the incentives. The incentives are placed wrong. Segmentectomy is technically more challenging. And the other thing is, as a new surgeon joins the group, and the older guys like myself will be sitting, and as you're doing segmentectomy and your length of stay is higher or longer, then that guy will be put in a spot that he is a worse surgeon because his length of his stay is, because the administrators don't know the much difference between a segmentectomy and lobectomy. They say your new surgeon is a worse surgeon because his length of stay is worse. So there are a lot of other factors go beside the technical part. And
an answer from Dominique?
No, it was just a suggestion that if you want to make more money, you can perform 1 + 2 or 9 + 10. Maybe that doubles.
No, what I'm saying, I'm just bringing the economy. In U.S. is still different. And training is another part, and we fortunately have a perfused cadaver robotic segmentectomy course where we perfuse the cadaver and do all the segments. So we're trying to provide more opportunity for surgeons to learn. But in U.S., what I'm saying is finances favor thoracotomy, finances favor lobectomy than segmentectomy.
That's about the comment about the economical and social things. So now it's time to close our session. Thank you very much, okay?
Okay, so come back at 3:30 and have a good break.
So in the interest of good timekeeping, I guess we should start quite shortly. If we do have our speakers, we'll start in 1 minute. Oh, hi. You're the first speaker. Good to stay on time here.
It should have 10 minutes, I think.
Yeah. And is there a 5 minute?
We have a clock adjustment?
Otherwise we can time, can't we?
Maddie?
What, it says 15 on here, but what are you expecting? Are you expecting 10 minutes or 15? Which, is it 10 minutes and 5 minutes?
10 and 5 because there's a discussion.
Okay. 10, yeah.
Yeah, 10. Yeah, 15
so 10
okay.
minutes?
15 is okay.
Yeah. So we were thinking 10 minutes? Is that okay? Yeah? Okay, good. Yeah. Are you... Have you prepared for 10 minutes or for 15 minutes? No. Which do you prefer? Have you 10 minutes? Okay.
10 minutes on...
Oh, right. Okay, 9 minutes is great. Yeah, we will set this clock for 10 minutes, so you can relax. You have a spare minute as well, if we get started. Yeah, yeah.
Yes.
I will check if there's any full preparation.
That would be a good idea. Just give it another 1 minute.
I know the Americans like their timeliness. Yeah, it's kind of cheeky when everyone comes in. Or do we alternate or something?
We should say 10.
Okay. Yeah. Hi. Hi.
I'm next from Rotterdam.
Are you still doing these mini yes, I do, yeah, micro-lobectomies, yeah. If you fancy coming up and watching and visiting us, yeah, we'd be very happy to have you. Yeah.
So, as I mailed, I run off our budget.
Oh yeah, we were trying to get you across, weren't you? We were trying to find a time, weren't you? Yeah.
In the first half of 2020.
Yeah, great, yeah, brilliant. Yeah, well,
DX is in The Hague, so I don't have travel expenses.
Yeah, no, it'd be lovely to have you along. It'd be great, yeah, thanks. Yeah. So we'll get started then, shall we? Yeah. Great, so if we'll make a start. So we're going to make a start now, and we're going to be giving each speaker 10 minutes, and then we do have 5 minutes for questions, and obviously there'll be big prizes for the best questions. So the first abstract is by Hirohisa Kato, and you're going to tell us about the intersegmental veins.
Good afternoon, ladies and gentlemen. I have no disclosure. Recently, thoracoscopic segmentectomy is widely performed for small-sized lung nodule. We had experienced thoracoscopic anatomic segmentectomy using 3D CT simulation, and it enabled to perform complex segmentectomy. In anatomic segmentectomy, the most crucial step is identification of intersegmental plane. To identify the segmental plane, the intersegmental veins, the inflation-deflation line, and as recent method, ICG method has been recently reported. We had utilized both intersegmental veins and the inflation-deflation line in anatomic segmentectomy. To assess whether this landmark facilitated precise thoracoscopic segmentectomy, we subjected the undetectable tumor. Undetectable tumor mainly showed ground glass opacity and tumor located in the deep parenchyma. We cannot identify the tumor location with palpation or visualization during surgery. Therefore, this undetectable tumor needs to perform more precise segmentectomy. So, the purpose of this study was to evaluate whether the intersegmental veins and inflation-deflation line facilitate precise thoracoscopic segmentectomy for undetectable tumor. Between March 2005 and June 2019, a total consecutive 441 patients underwent thoracoscopic segmentectomy. Among these patients, this study enrolled 152 patients with undetectable tumor, and it was difficult to perform wedge resection. Undetectable tumor was defined as non-palpable and non-visualized tumor during surgery. Then surgical outcome were retrospectively evaluated. We introduced our surgical technique in this slide. Our thoracoscopic surgery was basically performed from 1 to 4 port access and was used 5 mm scope. For the identification of the intersegmental plane, we refer to both the intersegmental veins and the 3D CT simulation and inflation-deflation line by insufflation to target segment for intersegmental line. In the identification of the intersegmental veins, 3D CT simulation was performed preoperatively. We identified undetectable tumor on thin section CT with axial, coronal, and sagittal view. Then surgical margin from tumor to intersegmental vein was measured using 3D CT simulation. We assessed whether the sufficient surgical margin secured. This 3D CT image was referred during surgery. And the inflation-deflation line was created by the air insufflation to target segment like this figure. The mean patient age was 60.8 years. Male was 72 and female was 80 patient, respectively. On the CT finding, mean tumor size and depth from Basilar pleural was 1.4 and 1.5 in diameter, respectively. In tumor characteristics, 39 patients exhibit solid, and 58 had a semi-solid, and 55 had pure GGO. In pathological diagnosis, most patients were lung cancer. 97, 40, and 15 patients underwent segmentectomy, subsegmentectomy, and segmentectomy combined with adjacent subsegmentectomy, respectively. The successful resection ratio for all segmentectomy procedure was 98%. Successful resection means that undetectable tumor was contained in resected segment. On the other hand, additional wedge resection was significantly performed in subsegmentectomy group. Additional resection was performed in order to secure sufficient surgical margin because the initial surgical margin was insufficient, though tumor was contained in resected segment. In successful case, one patient who underwent initial segmentectomy was aided wedge resection. 2 patients who underwent subsegmentectomy were converted to segmentectomy. The reason of a successful operation was misjudged of intersegmental veins and artery. Anomaly was bronchus. In additional resection case, all patients underwent additional wedge resection. Finally, could be secured surgical margin. Operative time was 184 minutes, and median blood loss was 52 milliliters. Duration of drainage and post-operative hospital stay was 1 and 5 days, respectively. 9.9% cases had prolonged air leakage as complications. Although conversion to thoracotomy was performed in 2 cases, there were no recurrences. I'll show actual video of the left subsegmentectomy. This patient had a 9 mm in size with semi-solid density in left upper posterior segment. We performed left thoracoscopic subsegmentectomy. Tumor was non-palpable. At first, the intersegmental artery was divided using an energy device. Second, the segmental bronchus was dissected. Then, the monofilament thread passed through the segmental bronchus. The bronchus was divided after selective closure. of the bronchus by slip knot method after inflation to whole lung. This is inflation diffusion line. Intersegmental vein were identified just between the inflation diffusion line. Peripheral site was divided stapler with a stapler. This is the intra-subsegmental vein was divided. This vein was intersegmental veins were preserved. Finally, the intersegmental parenchyma was divided with a stapler. Surgical margin is sufficient. Intersegmental vein was anatomical demarcation in segmentectomy, and 3D CT simulation was useful for the identification. And inflation diffusion line can be secured sufficient surgical margin by inflation to target segment. It is so that combination of the intersegmental veins and inflation diffusion line was simple, easy, and low-cost method, anatomical segmentectomy. That's all. Thank you very much.
To discuss the paper, we have Shanda Blackman.
Thank you for the opportunity to discuss this paper and for providing me the manuscript in advance to review for preparation. You're to be commended for your meticulous work in the area of segmentectomy and lung preservation, especially for patients who suffer from multifocal lung disease. I have several questions for you. Number one, how is this technique affected in patients with emphysema? With so much cross-ventilation, I've found this to be somewhat unreliable. And how is this technique affected by patients with lung adhesions or who undergo reoperation and have a lot of scar tissue?
In this study, almost case was not an emphysematous patient. About 10 patient is an emphysematous patient. When we performed thoracoscopic anatomic segmentectomy for emphysematous patient, we divide intersegmental veins and divide mostly inflation diffusion line along inflation diffusion line. Divided.
It's difficult. Okay. I'll just ask one more question. Have you compared this technique to more accurate technology such as ICG? I see that your slide said that it seems to be 10% better. I find that hard to believe. What do you think?
Yes. In our institute, we do not have ICG camera.
Okay. Perfect.
Yes.
Okay, thank you.
Any questions from the floor? Okay, thank you very much. I think we'll move to the next speaker. And the next speaker is Song Yun Han, feasibility of electromagnetic navigation bronchoscopy guided lung resection for pulmonary GGO nodules. Please.
Okay, thank you for inviting me. It's a great honor. I'm working as a fellow in Chungnam National University Hospital in Korea. I will talk about the EMB, which means electromagnetic navigation bronchoscopy. as we already know about this, but I want to focus on our experience, especially for the GGNs. Recently, radiologic technologies have been developing every day, so sometimes we encounter these kind of regions, and I think there are some concerns about what to do next. Before we move on, I prepared one article which talk about the natural history of pulmonary subsolid nodules. This was published in the Journal of Thoracic Oncology, 2016. There were 1,229 subsolid nodules were included, and they are followed up by mean follow period of 4 years. We have to see there were many pure GGN nodules, but after follow period, we can figure out there some in 5.4%. They converted to part solid nodules. Even though it's not a big number, we have to know that we have to do something in selected patients. So, in current guidelines for management of subsolid nodules, both of the NCCN and Fractional Society guidelines, they recommend when the nodule is bigger than 6 millimeters, or if there are some changes in size or presence of some solid portion, they recommend that we do some kind of biopsy or 3 or 6 months of follow-up CT. We have our own strategy for managing subsolid nodules. When the pure GGN, when its size is more than 15 millimeters, or size is getting bigger, or some solid portion is presents, or the solid portion is bigger than 5 millimeters, we consider surgical resection. Then, when we have to do a surgical resection, I think the most important and the most difficult thing is about the matter of localization. So, when we consider about the localization, we have to consider many things, such as how accurate we can go that region, or is there any complications such as hemothorax or pneumothorax? Isn't it take so many times? Should the patient have an inevitable radiation exposure, or does the center support this facility fully? Finally, doesn't it take too much money? So, but I think obviously the most important thing is accurate localization. When you do the lung surgery for the small lung regions, it's very sometimes difficult to identify the exact location. In the cases of GGNs, it's even more important for the localization, because GGN regions is invisible and not palpable in many cases. So previously, many methods for localizing pulmonary nodules are, but I think when we consider for the GGNs, we think EMB can be one good solution. So this study is find out the feasibility of EMB, especially for the pulmonary GGNs. We doing this procedure from 2017, and in this study, we included 33 regions. We excluded solid nodules or capital regions or only biopsy cases. So we have 16 cases of pure GGNs and 70 cases of mixed GGNs. And mean size of all nodules were 11 millimeters. And in cases of pure GGNs, you could find out there were 10 malignant regions, such as adenocarcinoma situ, or minimally invasive adenocarcinoma, or invasive carcinoma. And there was 6 cases of benign regions. In cases of mixed GGNs, we could find out there were 12 cases of malignant regions. There were 5 benign regions. So in short, there were 22 cases of malignant regions among 33 regions. So every cases, we can find out all targets were properly tattooed with the EMB, and the mean procedure time was about 18 minutes. We calculated this procedure time from the bronchoscopy insertion time to dye injection time. Of the 16 cases of pure GGNs, we performed 15 cases of wedge resection and 1 case of segmentectomy. And there was 3 cases of permanent basilar result as invasive adenocarcinoma, so we conducted a completion lobectomy afterward. In cases of 17 cases of mixed GGNs, we performed 5 cases of wedge resection. In these cases, there was invasive portion in frozen biopsy in 5 cases, so we converted to the lobectomy and that performed. And 6 cases show the permanent pathologic result as invasive adenocarcinoma. So just like pure GGNs, we do the completion lobectomy afterward. The success rate of dye marking was 100%, and the final pathologic staging was less than 1A. And there was, in all cases, there was no procedure-related complications or operative mortality. There are some limitations. This is a retrospective study, and it's conducted in single center. And we need some further evaluation of this because there are not many patients involved. But even though there are some limitations, we can find out that this EMB can be used for acute localization, especially for the GGN. It's because with high success rate and without complication. I think this EMB can be used more frequently, especially for the GGN, with many advantages in the future. This is the end of my presentation. Thank you for your attention.
Great, thank you very much for that very interesting presentation. And if I could ask Chris Cedar to discuss the paper.
Dr. Han, I'd like to congratulate you and your team for a nicely presented talk here and for getting me the data in advance. Subsolid lesions are becoming increasingly identified with the advent of low-dose CT scans and for screening for high-risk patients. But as you pointed out, you oftentimes can't feel or see these lesions, making something like this preoperative localization important for both the surgeon and the patient. The safety and efficacy of navigational bronchoscopy-guided localization and biopsy has been shown before, specifically by the Navigate trial, where they demonstrated a 92% accuracy in biopsy and 95 to 100% accuracy in other studies for localization. So I do have a couple questions for you. It looks like you excluded all the patients that had biopsies. Should you routinely biopsy these lesions at the time of your localization? That may, number one, cut down on the time in the OR to do the wedge resection, but also reduce that 33% rate of benign resections.
Thank you for your critical comment. We do this procedure since 2017. Actually, at first we do not biopsy in all cases, but recently we started to do the biopsy in all cases. So I think we are collecting the data. So thank you. I agree with you.
Okay. Some authors have reported that upper lobe lesions are more difficult to localize due to the acute angle that you need to come around with the navigational scope. Have you found any predictors of what makes it easier or more difficult to localize a lesion?
As you mentioned, especially when the target region is the anterior segment of the upper lobe, it's really hard to approach. But yeah, and in these cases, there's one cases of the when the nodule was anterior segment, but we do it pretty well. I think we do it pretty well. And to increase the accuracy of this procedure, I think the most important thing is meticulous and very careful evaluating the navigation route before the procedure. And the second thing is we excluded patient who has a very acute angle of the bronchus. So maybe that's a reason of our result.
again, congratulations, and thank you for the opportunity to discuss this.
Thank you.
Thank you very much. And our third abstract now is by Yun Suzuki. I'll ask him to come up, and he'll tell us about survival outcomes after thoracoscopic segmentectomy. That woke you all up, didn't it?
I'm sorry. Very sorry. I'm Jun Suzuki from Yamanashi University, Japan. It is honor to speak to you today, but I'm in the middle of studying English, so I think it will be hard to understand what I'm saying. So please be understanding. I'm no COI. Nowadays, so many small subdural tumors have been detected using CT screening. To know the condition of non-invasive tumor on CT, Japanese prospective study about mixed DGO was conducted by Japanese Clinical Oncology Group. In the results, the consolidation tumor ratio 0.25 and less than 0.25 were considered to be non-invasive with a specificity 98.7%. According to the study, they have completed registration for the 3 sublobar resection trial with more than 1,800 cases in total. We are awaiting for the final result. So, indication of segmentectomy is established in Japan. There are little data regarding the benefit of the thoracoscopic segmentectomy. However, indications for use of thoracoscopic segmentectomy are recently becoming more widespread because of the effectiveness and minimal invasiveness of the procedure. We have more than 350 cases of thoracoscopic anatomical segmentectomies for lung cancer at our institution, and we previously reported on the use and effectiveness of thoracoscopic segmentectomy achieved by multi-detector CT for use in respective anatomical interpretation, what we call samurai method. This method needs to probe good long-term outcome because this is not only for surgeons' self-satisfaction, but also for cured lung cancer. So, the aim of this study is to describe method of thoracoscopic segmentectomy in our institute and to evaluate the short-term and long-term outcome of our thoracoscopic segmentectomy. So we reviewed data from 766 consecutive patients who underwent pulmonary resection for lung cancer from January 2004 to December 2014. Cases that were converted to lobectomy, operation for second cancer, pathological diagnosis of AAH were excluded. Finally, we analyzed 130 cases to evaluate the short and long-term outcome of thoracoscopic anatomical segmentectomy. The basic selection criteria of curative intent operation was as follows: a tumor size less than 2 centimeters and solid component ratio less than 0.5. The selection procedure between weight reduction and segmentectomy depends on the tumor location and the DGO ratio. When simple segmentectomy alone was assumed to yield inadequate surgical margin or margin to tumor diameter ratio under 1 was anticipated, segmentectomy combined with adjacent subsegmentectomy or multiple en bloc segmentectomy was planned. During the procedure, the surgeon stood on the ventral side of the patient and the assistant stood on the dorsal side. The image on the side of the assistant was loaded 180 degrees. 4 ports were prepared for the port access technique. Recently, uniport procedure is studied to limitedly. We first dissected the pulmonary parenchyma along the intersegmental vein using an energy device or an electric cautery, and the intrasegmental vein was identified. The division of the intrasegmental vein allows for the identification of the intersegmental border and facilitates further parenchymal dissection. Subsequently, we could reach the target artery and bronchs. Another important thing is how to demarcate intersegmental plane. We previously showed that determination of the intersegmental plane using inflating affected segment enables anatomical precision to dissect the pulmonary segment. Also, as target lung is inflated, this method leads to maintain the sufficient surgical margin. We reported slip knot method to simply and easily to demarcate ID line. This method is effective for smaller bronchs to doing complex subsegmentectomy. Resected segment is as follows. We have tried not only simple segmentectomy, but also complex, more difficult segmentectomy such as these. This is left side. So, age, community index, solid diameter, and CT ratio were higher in the compromised group, limited group, than in the curative intent group because compromised limited resection was performed for high-risk patients. The number of easier and simpler segmentectomy was higher in the compromised limited group than in the curative intent group. The median amount of bleeding was 4.5 and median operative time was 190 minutes. Conversion to open thoracotomy was performed in 2 cases. Post-operative complications occurred in 10 cases. Histology almost adenocarcinoma, local regional recurrence as a first relapse occurred in 2 cases, and no distant recurrence was found. Local regional recurrence was only observed in the compromised group. One patient underwent compression lobectomy, and the other patient was elderly. Surgery was not performed. The 5-year OS rate in all cases in the curative intent group and in the compromised limited group was 91.8, 98, and 74%, respectively. The 5-year OS rate in the curative intent group was higher than that in the compromised limited group. The 5-year cancer-specific rate in any group was 100%. The 5-year recurrent-free survival rate in all cases in the curative intent group and the compromised limited group was 98.1, 100, and 91%, respectively. If we perform a segmentectomy, we can remove the regional lymphatic pathway around the tumor, so anatomic segmentectomy could be applied even for invasive tumor. However, if we perform wedge resection, the tumor cell may persist within the lymphatic pathway. Therefore, non-anatomic wedge resection should be applied only for non-invasive tumor. I mean, CT ratio less than 3.25 tumors. Dr. Salvat and colleagues reported that the surgical margin less than tumor diameter was associated with a higher rate of positive resection margin. Dr. Stewart and colleagues checked as surgical margin tumor size in recurrent cases after segmentectomy. They reported that the surgical margin less than tumor diameter was associated with a high rate of recurrence. Table shows studies of limited resection, including segmentectomy for curative intent patients in Japan. Our data shows not inferior to the previous studies. According to our selection criteria with detailed 3D simulation and trace the intersegmental vein, we had the affected segment to make the ID line and the sufficient surgical margin. Representative case, 68 years man who suffered multiple lung nodule, and we performed this kind of sublobar resection. This kind of case is rare, but sometimes we experience multiple nodule cases like this we should consider how to treat these nodules. Thoracoscopic anatomical segmentectomy under 3D CT simulation is an acceptable technique to assess the long-term outcome in selected patients with non-small lung cell cancer. According to these data, our thoracoscopic segmentectomy is acceptable given the long-term outcome in selected patients. That's all. Thank you very much.
To discuss the paper, we have Matt Schuckert from the University of Pittsburgh. Please.
Dr. Suzuki, thank you very much for this excellent presentation. Your group, including Drs. Oizumi, Kato, and Sadahiro from Yamagata University, should be congratulated for these outstanding technical and clinical results and for your contributions not only at this meeting, but over the years in the realm of segmental lung resection. We anxiously await the results of the Phase 3 CLGB and JCOG studies to clarify the role of segmentectomy in the management of solid non-small cell lung cancer. In this series, the authors report outstanding oncological outcomes in the use of segmentectomy in a very carefully selected group of patients, clinical T1N0 tumors with a predominantly ground glass component, with a consolidation to tumor ratio less than 20%. The overall complication rate was outstanding at 8.8%, and no perioperative mortality was observed at 30 days. At a mean follow-up of 73 months, there were only 10 total deaths, only one of which was deemed cancer-related. I have 3 questions, and I'll ask them individually for your response. Your group has highlighted the use of 3D multi-detector CT simulation during segmentectomy to evaluate the segmental anatomy and the potential adequacy of surgical margins. How do you physically incorporate this into your workflow? Is this something you do in clinic, the night before the procedure, in the OR during the procedure? Does it help you intraoperatively? And lastly, is this system commercially available?
You mean how simulation?
Yeah, so in your use of the 3D CT imaging, when do you analyze that data? How do you incorporate that in preparation for the case?
So prepared before surgery and during in our institute, there is a 3D CT. We can see the 3D in during surgery. So we use the mouse to use. We can use the.
So you can use the 3D image during the procedure to map the branches.
Yes. Oh.
Recognizing that these lesions are predominantly ground glass and not palpable, what is your method for assessing the adequacy of margins? And do you have any data in this study on margin distances and margin to tumor ratio assessments?
I beg pardon, 3. I beg pardon, please.
Yes. How do you assess your margins during these anatomic segmentectomy when you're dealing with a ground glass nodule? Is it purely by frozen section? How do you assess the adequacy of your margin?
So after resected the lung with cancer, so we check the operative surgical field and check the margin. So we don't perform the I'm sorry.
So frozen
for the margin.
I'm a co-author of this paper. I'm with me from Yamagata University. We usually cut the lung parenchyma in the operative field, and we ourselves measure the surgical margin. And when we can't get the surgical margin sufficiently, we sometimes cut the put the additional removal. And maybe for your question is about the, especially on the GGO.
Yes.
Yeah. We sometimes, nowadays, we think the GGO is not invasive, so the margin of the surgical margin is becoming a little bit smaller, actually.
Very good. And one last question. Did you encounter any nodal involvement in these patients that were clinically N0? And if you did encounter an N1 lymph node, how do you typically manage that at the time of segmentectomy?
About lymph node?
Yeah, if you encounter positive N1 lymph node during the procedure.
We change the lobectomy. Yes.
Okay.
Thank you very much.
Thank you. I'm sorry.
We'll let you off.
So now we'll change the pace, and this next session will be a video session.
So if anybody has some glue, then I'll just put the lectern back together again. But I'm sure we'll make do with that. So we're going to have a few little talks about some different types of segmentectomy, and I get the easy one, which is great, the lingular resection. But I thought I'd just do one where you can watch me struggle, because this one was a little bit more tricky. This was a typical carcinoid, as shown on that indicator, and I thought this was going to be a piece of cake. I thought I might have to do some chopping, so I thought I'd use robotics. I split between robotics and VATS, and so for this one, I've got a lung grasper, Cadier and Maryland, and I do a sort of 5-port technique. So the first disappointment was adhesions. Ah, shucks, because a lingulectomy is really wonderful if you've got a good fissure, but because the carcinoid had collapsed the lingula, it was pretty stuck. And the most disappointing thing was that it was really stuck on the pulmonary artery. So as you can see there, I gave up on the pulmonary artery. I thought I'd come to the front, and as we're all taught to do, we need to do a good lymphadenectomy, taking away some station 12 lymph nodes, some station 10 lymph nodes, trying to take them completely. I have an anterior utility incision for my assistant, and I quite often like a subxiphoid anterior utility incision. So this is the lingular vein. It was tiny, so probably quite a lot smaller because the lingula had been chronically collapsed. Now, pretty stupidly, I thought I would try and staple this. That was clearly far too small for stapling. What an idiot. Oh, my God. So for some reason, I was probably being paid by Covidian to use their staples. But literally one buzz of a diathermy, and that would have been history, wouldn't it? Anyway, once you've taken the lingular vein, you can then take out the lymph nodes to try and discover the space between the lingular bronchus and the artery. But it was still stuck. Now, I was absolutely confident that the bit that was stuck on the pulmonary artery is just chronic collapse, because this was histologically proven typical carcinoid, and it really isn't going to have spread out, and it's not going to be tumour. But I couldn't really get it off the pulmonary artery very easily. I tried the front of it and tried the back of it. So then moved to the back, and I've got the posterior oblique fissure there, so we have a little nibble at that. You might notice I kind of use a Sofolio pick and burn sort of technique. Other people like Bernie Park do much neater little spatula type diathermy. And then I thought I'd try and approach the pulmonary artery from the other side. Just like René showed yesterday, I like to have a cigar or swab in the field to keep things dry. And now I'm trying to come from the other side to get this bit of adhesions off the pulmonary artery. Obviously, robotics is nice. You can be your own assistant and be your own cameraman, which is nice. And so now we're just approaching from anteriorly, trying to just get finally this bit of lung off the pulmonary artery. And actually, while the instruments don't have any tactile feedback, I do think they do have some pretty good visual feedback, although it was slightly worrying, pushing, trying to get past the pulmonary artery. But finally, I did get to the other side of this bit of dense adhesion. lesions. You can see that I've got a cross, and now I can just burn to make a little space to get through. And I'm absolutely confident that that isn't going to be tumor, it's just going to be some collapsed lingula, so that's safe to staple. So I do my staplings from anteriorly. So I prefer to get the cadia through in difficult spaces. I don't really like that nasty pointy Maryland poking into pulmonary arteries. So I do this little handshake technique just to get the sharp Maryland through, and then I can use the leader cath. I find the leader cath completely useless in VATS lobectomy, but I think it is really very useful when you've got some quite junior assistants helping you on the table, so you can literally just pull the stapler across. Oh, suddenly I'm in nirvana heaven time. So you can finally see the pulmonary artery. I can see the basal pulmonary artery, segment 6, and finally I can get that out, and that's going to make things simple. So I can complete the posterior oblique fissure, which just makes that nice and easy now because I can see everything. I didn't even need a leader cath because there was even enough space for my rather junior assistant to hit it. And now I'm ready to take the artery. So I've taken the vein already, which was tiny, and now I need to take the lingular artery. It's quite a big, decent-sized one. Again, there are a few little adhesions, and just made sure I wanted to dissect it out. It didn't seem to break into 2 branches at this point, so I thought I could go around it. And I was having a good look at the lingular artery, because remember, this is a proximal carcinoid, so I was not going to be able to staple the bronchus. So again, using the little handshake so that I can bring the leader cath round to make my life easy, because it does make me very stressed letting someone else bring the stapler around these small vessels. Staple that with a Covidian gold tip, and now we're ready for the bronchus. So the bronchus needs to be cut. So I brought in the robotic scissors, and we'd seen already bronchoscopically where it was. I also sort of dissect a little bit distally, and I think you can actually probably even get an impression of seeing where the tumour is actually going to be. So it's just there. So just proximally of that, we're going to cut the bronchus with the robotic scissors. And my plan was just to look from inside and just see what the margin is. I'm pretty disrespectful of typical carcinoid margins. I think as long as you've got a margin of a good sort of 4 or 5 millimeters, you're going to be absolutely fine. You can visually see from inside and outside quite nicely. And as you lift up, you can see the carcinoid just winking at you there, just giving you a little wave. There it is. And suddenly your life's easy. Brilliant. I can just cut around that. Anyone could do this now, couldn't you? So this is just really nice and simple. I think I was actually going into the specific segmental bronchus, leaving behind the segment 5 bronchus. So I've cut the segmental 4 bronchus there, and there you can see it poking out, and I'm going to send that off for frozen. But also this was the other segmental bronchus of the lingula, and I thought, well, you're not going to take half a segment for lingula, so I'm just going to cut that, and also I send that off for frozen, just to make absolutely sure we've got a margin. You do get a few little bronchial vessels. There's a little bronchial vessel, but luckily you've got some electrocautery on your scissors robotically, so we can deal with that pretty easily. And I just thought I'd just chop a nice little frozen margin, send that off. And so while we're waiting for that, and we're obviously going to take the lingula at this stage as well, we're going to then need to suture the lingular stump as well. So this is just completing the lingulectomy, making sure your vein, artery and bronchus are securely in your sample, and just nicely stapling. As I say, I quite often use a subxiphoid assistant port. I find this means you can actually see the assistant port quite nicely. If you put your drain through the assistant port, it hurts less if it's subxiphoid than intercostal, although obviously these drains often come out quite quickly. So while we're waiting for the frozen section, I really like to get out 4-0 V-lock. I think this is just the most fantastic suture ever in the world. It means I don't have to tie knots. You just have to hit that circle, hit the little eye, and then just tug. Now, I'm only using the lung grasper to tug the 4-0 V-lock. 4-0 V-lock can very easily be fractured. Don't ever hold it with a needle holder. You will just break it and snap it. So I'm using the most gentle instrument I can for holding it. But you can see robotics is really good for suturing. I think there's not masses in it for VATS versus robotic for standard lobectomies, but when it comes to suturing, it really does make it very easy indeed. The other thing I do here is I don't actually tie a knot at the end. All I'm going to do is loop the knots a few times and just sort of, so I'm not even going to tie a knot at the end because the barbs of the 4.0 V-lock is going to keep this nicely secure. Which again is a really nice use of it. The prostate surgeons use 4.0 V-lock all the time, and they can't tie knots. So I thought I wouldn't bother either. You just loop it round a few times, and Bob's your uncle, as they say in England. So this is just looping it, and I did that a few more times, and that actually held it perfectly securely. And that's the bronchoplasty performed. That's really it for this robotic thing. And the only other thing I did want to show, apart from taking it out, is that hopefully this time next year we're going to be using a different robotic system. In the UK, we've got a company called Cambridge Medical Robotics, and they've done 110 clinical cases with a system called Versius. We always, by the way, we tunnel an intercostal catheter and a single drain and inflate and make sure there's no air leak. But next year we're going to be using Cambridge Medical Robotics, probably from about 3 or 4 months' time. As I say, there have been 110 cases done. We haven't done any clinical cases yet, but this is just a quick 1-minute view of the new Versius on a cadaver. It's got as many arms as you like. They're all on little individual gantries. The clever little thing is you just roll the arms round to find the remote centre, and it'll just remember where the remote centre is. There's a lot more space for the assistant, and then they've got a cool Xboxy kind of hand gadget, so there's no foot pedals, and the really good thing about no foot pedals is you can stand up. At the moment I'm planning to double glove so I can go straight back to the patient, but they've also promised me to have some sterile covers for the holder. And the other real game changer is it is very cheap, because it's British and everything's cheap in Britain. So hopefully this time next year I might be able to show you a Versius case, but that was a lingulectomy robotically. Thank you very much.
Thank you, Joe, for this excellent video. We have time for a question or two. Yes?
You're holding up a much better speaker than me next, by the way, so
Just a very quick question. I noticed you weren't using the robotic stapler. Is it just a cost issue, or is there any other reason?
You'll be horrified to hear that I have that old thing called an SI. You might remember from the old photos, but the SI doesn't have a stapler, so we don't have the staple upgrade. So, Scott.
Great video. I've done some of those lingular bronchoplasties like that. The only question I would have is, you put quite a number of stitches in there, and sometimes that distorts the airway and you get a little speed bump. Did you have any issues with that, or when you put that many sutures in, does that affect your closure in terms of the contour?
Yeah, no, it's a really good point. So we've got I look from inside with a bronchoscope as well, and I do worry about that a lot. And so I do check bronchoscopically all the time. We've actually got some video bronchoscopes. I'm sure you do as well. So I get to see from inside and get to see from outside. So hopefully I do avoid that. And V-lock is absorbable as well, so it won't stay there. Whether that's important or not, I don't know. So if there aren't any more questions, I was just the warm-up act for a far better speaker, René Peterson. I've had the great pleasure of visiting him on several occasions, and he's going to show us a proper segmentectomy.
Thank you very much. And these are my disclosures. I work with Cavilion and receive speaker's fee, which is relevant for this talk, I believe. This is the standardized anterior 3-port approach that we've been using in Copenhagen for many years now, and I used for this segmentectomy as well. So the patient had previously a VATS lobectomy on the middle lobe and had a synchronous carcinoid in the left upper lobe's segment 3. There were normal lung function tests, and this is the CT scan, and you can see it's rather deep in segment 3. Unfortunately, I didn't have 3D reconstruction at the time. You can see the tumor there. We use this sponge stick. It's a philosophy. I like not to grasp the lung, but to gently push the lung and be atraumatic in handling lung tissue. I prefer nowadays to use a ligature for dissection. So when the hyalopleuris dissection, and the upper lobe vein is dissected. I identify the segment 3 vein. This is divided using a tan cartilage. I always divide the inferior pulmonary ligament and localize the inferior vein on the left side. You can be mistaken by a common trunk and by accident dividing the entire vein. Then the artery, the superior trunk, the part of the superior trunk going for the third segment is divided, and in this case I decided to use the ligature. And for arteries of this size, I put a hemolock on the central part and divide the distal part with the ligature, as you can see now. So next step is to identify the bronchus and identify. In doing this, I chose to divide the fissure between lingula and segment 3 because there was a part of a fetal fissure which could guide me for this and make it easier to get a central access to the segment. So to the right you see the lingular segment, and to the left of the stable line you see segment 3. And this intersegmental plane was divided using a purple cartilage. If it's very thick, I'll use the black cartilage. There you see the lingular segment with the lingular vein. And again, gently pushing with the peanuts. This is the philosophy. And checking that the tumor margin is sufficient. In this case, you see the tumor very clearly. I'm just palpating, making sure that it is sufficient. And next step will be to approach the bronchus. And my experience in segmentectomies is that you really have to take, when you come from lobectomies, you have to take your dissection to the next level, which is, I learned a lot from doing segmentectomies. I believe I'm better at doing basalobectomies after having experience in segmentectomies. Your anatomical knowledge becomes better. And so now the bronchus for segment 3 is identified. I've seen behind this the bronchus for lingula and the bronchus for segment 1 and 2. I use, in this case, because it's a small bronchus, I use the tan cartilage. I compress the bronchus and use the inflation-deflation technique. And in this patient with a normal lung function, you see clearly the margin between segment 1 and segment 3, and you see that the remaining lingular segment is well inflated, and so the bronchus is divided. And next is to approach the intersegmental plane between segment 1 and segment 3, and it's still clearly marked after the inflation-deflation, keeping distance and making sure not to compromise the venous drainage from segment 1 and 2. I keep a Babcock, as you can see, in the hilar structures to make sure that I have the hilar structures on the specimen side, and especially for lower lobe segments not to have a rotation of the segment and to keep orientation. It's an advantage always to keep an instrument in the hilar structures. Then the tumor is removed, and since this is a typical carcinoid, I'll perform a lymph node dissection. And just a few words about the lymph node dissection. In the aortopulmonary window, I like to identify the vagus nerve. When you identify the vagus nerve on the top of the aortic arch, you can also identify the recurrent nerve. And when you see the recurrent nerve, the lymph node dissection is much safer. You can see there's the recurrent nerve and the vagus nerve to your right. And this is the subcarinal area in the station 7 area. I like to free 2 centimeters of the opposite main bronchus and checking the margins, and you can see it's a very small piece of lung that is removed. The patients had an uneventful course and length of stay was 2 days. It was a typical carcinoid. There were 14 lymph nodes removed, and none of them were with cancer, and the duration of surgery was 100 minutes, and the blood loss was insignificant. Thank you very much for your attention. And great questions.
Fantastic, a beautiful presentation. Does anybody have any questions or comments? Would everybody have taken 14 lymph nodes with a typical carcinoid? I think that's a fantastic effort. I might have skipped a few.
Thanks very much. Can you show us where was A1? I was struggling to see where A1 was. You took the first branch of the pulmonary artery and you call that A3?
Yeah, there was one behind it.
So when there's two in parallel, how do you decide which is the A1 and which is A3? Yeah?
Yeah, that's a good question. Well, to decide that you need a 3D reconstruction, right? And I think this has been advocated very well by Dominique Gossot during these meetings. We've just got the possibility now to have a 3D reconstruction. We didn't have it at the time of surgery here. It's definitely going to change your strategy, I think. Whether how significant it has for the clinical outcome, I'm not sure. But,
okay. Well, it's an absolutely excellent video. Thank you very much again, René. And now we've got great pleasure in inviting Scott Swanson, a true giant of segmentectomy as well as lobectomy, to show us a beautiful apical segmentectomy.
Thanks, Joel, and Renee, and everyone here. It's been a great session so far. So this is a case of a 78-year-old woman who fell and broke her clavicle, and when she had x-rays for that, they noticed this mass. And somebody was talking about doing a lobectomy for this and possibly through a thoracotomy. So, I don't know if I can... You can see the mass there. We're palpating it. Now we're dissecting out the artery to the apex, as you can see. And pretty straightforward. I would say to Renee, you don't need a clip if you don't want to put one in. Energy works fine without it. And occasionally I've injured the artery putting clips on, so I think you can consider not doing that. Here we're getting around the apical bronchus. And I would say that the vast majority of segments we take, another point is for these segmental bronchi, we found that you can use the vascular staple load. It's a little bit smaller, easier to pass in, and the 2 rows work fine. Probably done 30 that way. And here we are creating the fissure. The vast majority of segments, I take the veins separately, but in some of these single segments, I think some of the time the vein is coming intersegmental, and you're going to end up taking more vein supply than you wish, and you compromise the remaining segments. So we'll sometimes not take a specific segmental vein for the single basilar segment or in this case, this segment. And I'm not sure, I mean, whether it clinically makes a difference, but I think it does potentially avoid venous congestion. And again, like Renee will show the path report, here's making sure everything comes up nicely, testing our stump, and similar kind of outcome to what Renee had in terms of length of stay. And the path report, we took 4R and 7 and all the Hyler nodes, and all were negative, and get all this data, but we didn't see any STAS. The tumor itself was on this next, did I already show that? Yeah, the tumor was 2.1 or 2 centimeters, and the margins were widely negative. So again, for a small, well-situated tumor, I think it can do a good job. I don't know how people think about STAS and segments, we've still been doing segments in the setting of STAS and carefully watching our data, but certainly wedge resections, we're a little more nervous about leaving STAS behind and converting to either a segment or a lobe. But I think apical segment is a pretty straightforward segment to do now, although I'd say 5 years ago that was a much harder segment for me to consider. And that's pretty much it. Thank you.
Thank you very much, Scott. I would like to start with one question. So why do segmentectomies in right upper lobes, especially if you have a patient with a compromised lung function? There may be an LVRS effect of removing the right upper lobe. So
it's a good question, and I'd say until about 3 or 4 years ago, that was my stance, was why do them? And I'd say the main reason, and not necessarily in this case, is most people now that have a partial solid ground glass lesion, you can see with these high-res CTs 1 or 2 other lesions elsewhere in the patient, and I think you're going to be dealing with those at some point in the future. So I think preserving segments, functional segments, is reasonable. If you're going to go that road, I'd definitely get a DQ scan or carefully look at the CT and make sure the upper lobe was a significantly diminished lobe before sacrificing the rest of the segments. I think the posterior segment's straightforward. Apical is not too challenging either, but if you do see heterogeneous emphysema and they are compromised, I wouldn't hesitate to take the whole lobe. But again, with this histology changing, we're seeing 2 or 3 lesions in a patient that we're following, and one we're going to take out, and we know the others are coming right behind it. Please.
I'm Dr. Shiono. I would like to ask you about STAS. So in the case of with STAS, tends to have a local recurrence or local regional recurrence. So you mentioned about there is no STAS. If you have a case with STAS in pathological diagnosis, you will do a completion lobectomy or not?
First, I bitch and moan that the pathologist noted it, because you never hear about in frozen section. It's always on the permanent. So I would look at a lot of the clinical variables, how old is the patient, how functional, try to quantitate the STAS. So with our pathologists, we've been saying, is this, we'll sit down and look at it. If there's a few tumor cells away from the margin, that's one thing, but if it's kind of loaded, that's a second problem. So if it's loaded with STAS, then I would recommend going in and completing the lobe. Mm-hmm. And usually, the patients don't really want to do it, but if you push hard, they'll go for it. Our pathologists who are dedicated lung pathologists aren't so certain what STAS means yet. They haven't totally bought in to STAS. So I think we're a little more on the fence about what it means at this point than perhaps the memorial pathologists and others.
Thank you.
Thank you very much. That's fantastic. Thank you very much, Scott. And now I have great pleasure in introducing again Dominique, our true genius and Yoda of segmentectomy. And actually, I would also personally like to thank you for the huge amount of work you put in this conference. You have actually personally done an unbelievable amount of work, so thank you for that as well. And I'm looking forward to your presentation on posterior and apico-posterior segmentectomy.
Thank you very much, and I'm also grateful to the previous speakers because you have kept on time, so that maybe I will not have to beg for 1 or 2 minutes more, because I'm afraid that this presentation will be a little bit long. So segment 1+2, I think it's something where it's now accepted, but I remember a couple of years ago when we were discussing this patient at a staff meeting, the question was always the same: why not performing a lobe just to spare segment 3? So I hope that you will see at the end of this presentation that it can be helpful. So I will not detail again my disclosures. For those who were yesterday at the conference, there were very nice pictures showed by Masaki Sato about the fact that the right upper lobe, it's not only 3 bronchi, sometimes it's mainly 2. So you have to adapt yourself to the situation. So that's why for a GGO or an early stage lung cancer in segment 2, you may do several operations like these ones. So we do it as we perform a right upper lobectomy in our department. So it's a posterior approach based on the fissure, as would William Walker say, using multiple port, a deflectable scope, and a scope holder. So we open the fissure, control the ascending A2, the bronchi, the arteries, and end up with a vein. So a few words about the anatomical landmarks for these operations. So we are talking about segment 1 plus 2, but usually the bronchi are actually separated. But as shown yesterday by Masaki Sato, there are variations in the distribution of bronchi, so you have to adapt yourself to this situation. Regarding the arteries, of course, the vascularization of segment 1 and 2 is an ascending A2 coming from the PA in the fissure, and a segment 1, an artery A1 coming from the truncus anterior. But sometimes, as shown yesterday during the anatomical session, the ascending A2 is missing. It's important to know the presence of recurrent A2, which is quite frequent, about 2/3 of the patient. So sometimes after when you see the arteries from a posterior view, you can have only 2 arteries, the ascending A2 and the A1, or the recurrent A2 as shown by the arrow. Of course, you know this variation, a common trunk between ascending A2 and A6. This is why it's very important to fully open the fissure, not to take the risk of damage of the A6. The ascending A2 very frequently is hidden by a V2T, V2 transversal, that you have to control before dividing the ascending A2. Now we move to the technical steps. So we first open the fissure. When the fissure is thick or too long, we make it shorten, either using a vessel sealing device or a stapler like this. We don't control the ascending A2 before doing this task, because as you see, when the fissure is open, it's much easier to have an access to the ascending A2, as you see here. Then we divide the V2T, and this is how it looks when the fissure is fully open. So usually you have only one ascending A2. Sometimes you have 2 branches, and when there are 2 branches, the one on the right is usually for segment 3. Take care to the lymph node. There are always lymph nodes at the bifurcation between the B1 plus 2 and B3, as shown on the book of Nomori and Okada. And you see that it's very similar to this operative view. So these lymph nodes, they are always removed, sent for frozen section. And if ever positive, you have to convert into a right upper lobectomy. So this is how it looks like when the fissure is fully open. And then you control the bronchi. So even sometimes it's B1 plus 2, as on the right side, and sometimes independent bronchi. So when the fissure is fully open, this is view from a posterior approach. You have the right upper lobe bronchus. You dissect it and see the origin of B3, but you don't know what is exactly this bronchus. There is nothing that indicates to you whether it's a B1 plus 2 or a B2, especially if there are adhesions or lymph nodes. So don't panic, take time, dissect it carefully. You isolate the recurrent A2. You still don't know exactly whether it's B1 plus 2 or B2. You get around this bronchus, staple it, and here you see that there is a bronchus behind, which is B1. So if you don't have B1 plus 2 in one shot, you can do that in 2 steps. And in this case, it was even worse. We divided B2. I think the bronchus behind was B1, but it was just B1A, and B12 was very far away. Then, once it's done, you control the A1 artery if you are performing a B1 plus 2. And of course, if there is a recurrent A2, you control these 2 arteries. The vein, you can control them either in the fissure or from a front dissection. So this is a V1 plus 2. And when it's done and you are ready to staple it, it's, as I don't know who said that during the meeting, but it's very important to keep the bronchial stump away from the forthcoming stapler. So you pull up the bronchial stump and dissect it at least on 1 centimeter, if possible on 2 centimeters, that it will keep away from the staple line, like this. Then you delineate the intersegmental plane. If you don't have the indocyanine green, you can do that by inflation-deflation. As you will see, it works, but it has the major drawback of taking place in the operative field. Then you staple it, always keeping an eye on the bronchial stump. Like this, okay. And of course, if you have the chance of having infrared imaging, it's much easier, like this. So this is extracted from the book of Nomori and Okada, which makes segmentectomies very straightforward, as you see. Then stapling. And this is how it looks like at the end. And I hope that it shows to you that sparing this segment 3 is quite important. I mean, if you want to make your jogging in Hyde Park tomorrow, it's nice to know that you have this segment 3 that participates to your lung function. Another case like this. And when you reventilate, this is how this remaining segment 3 looks like. And this is a reconstruction, 3D, 3 months after, like the lapsus, 3D, 3 months. No, 3 months after segment 1 plus 2. And you see that this segment 3 is very nice looking. Nothing special to say about segment 2. So in summary, it's finally just like an upper lobectomy, but with a dissection that is a little more in depth. The posterior dissection that we are using for our right upper lobectomy is very helpful. Remember that the anatomy is highly variable, and it's always useful to have a preoperative modelization. Extensive lymph node dissection is mandatory in order to switch to a lobectomy if ever they are positive. And contrary to other segmentectomies, the intersegmental plane is usually simple to divide. Thank you very much for your attention.
Thank you very much for a wonderful series of videos and all your previous presentations. Eric.
Thank you. Great presentation. I've got a question. Why is there a dogma that if the lymph node is intersegmental lymph node is positive, you have to convert to a lobectomy? What happens if you don't? It's the same analogy as if you do a lobectomy and station 11 is positive, would you then convert to a pneumonectomy?
Well, this is a question I have about 20 times per year. The answer is quite simple. There is nothing to see between a switch from segmentectomy to lobectomy and from lobectomy to pneumonectomy. So, of course, theoretically, if you are performing a lobectomy and the interlobar lymph nodes are positive, the reason would to switch to a pneumonectomy, but you don't want because you know that you will kill 10% of your patients. So this is not the case when you switch from segmentectomy to lobectomy.
Sorry, just so I understand, the decision is not about cancer clearance, it's about lung preservation. So you're happy to sacrifice a segment, but you're not happy to sacrifice a lobe. And that's the basis of your decision. But it's not about cancer clearance, it's about lung function.
Yeah.
So in other words, you're saying that it's okay to have a higher recurrence. It's theoretic, right? There's no randomized trial. So this is all very theoretic discussions. It's okay to accept a higher recurrence rate, presumably is what you're thinking, because you don't want to remove the lung, but you would sacrifice a segment to reduce the recurrence rate based on a loss of another 5% as opposed to 25% of lung function.
No, I'm sorry, I'm not sure to understand the question.
So just to reiterate, for a
But
segment,
this is
sorry?
basically
For a segmentectomy, if the lymph node is positive, you will convert to a lobectomy.
Yes.
Because you're happy to sacrifice 5% more to get better cancer clearance.
Yes.
But for lobectomy to pneumonectomy, you will not do a pneumonectomy because you're not willing to sacrifice 25%. But the risk of cancer recurrence, in your opinion, is the same, i.e. higher if you do not do a complete.
Yes, I agree with you on this point, but I just say I don't want to take the risk of higher mortality, because if you compare segmentectomy to lobectomy, the increase of morbidity and mortality is rather small. You switch, let's say, from 0.5% to 1% or 1.5. It's not the same when you switch from lobectomy with a mortality of 1.5 to pneumonectomy, which is a very high risk, around 8 or even more. So,
but don't you think that the pneumonectomy death is not about, or the amount of lung you resect is not really the biggest component of pneumonectomy deaths? Pneumonectomy deaths tend to be occur because tumors are central, they're hilar, they are big, it's difficult dissections, surgeons go into the, in this case, we're talking about lymph nodes. So I don't think that the comparison between a pneumonectomy death is the same as you would because a lymph node is positive versus a central hilar bulky tumor where the person dies because of a technical surgical error.
But I'm speaking about operative mortality or post-operative mortality, not of mortality because of oncological reasons.
I do entirely get the point. Has anybody here completed to a pneumonectomy because of the lymph nodes? So, yeah. So yeah, it's rarely done, but I get the point entirely. Scott?
And I think the data to go from segment to lobe for node disease as a better cancer operation was a little shaky. And there was a paper presented at this meeting last year that showed there was no improvement in cancer survival converting from segmentectomy to lobectomy for N1 disease. That's our dogma, but I'm not sure. It depends on what N1 node we're talking about. If it's an N1 node that's in the drainage of the segment, you've done a nice dissection, that probably doesn't need to be a lobectomy. But if it's a node between the segment you took out and the segment you're leaving behind and it's potentially draining the other segments, then that may make a difference. I don't know that we have that granular detail to know. So when I do it, if it's a node that's right in the segment I'm taking out and all the other ones are negative, I'm not sure lobectomy will improve that situation. If there's segmental nodes that are related to the remaining segments, then I would convert it. So I don't think it's as clear as it might seem.
Yes, I agree with you. We are just talking about a theoretical risk. I just want not taking that risk of having a patient recurring 2 years after my operation. I say, well, maybe I should have enlarged the resection. But I can't prove it. I cannot prove it. It's true.
Okay. Thank you very much, Dominic. We are coming to an end of this wonderful meeting, and I'll ask Joel to wrap up these 2 days and with all the highlights, please.
Thank you very much. Well, I'm afraid you're going to have to listen to me a little bit longer because Dominic, in his wisdom, has asked me to see what I've taken away, not just from today, but from yesterday as well. Yesterday we did hear some really interesting talks. And what I've been doing in these small meetings, because it's the small meetings where you get to hear the leaders in our specialty, I've been looking for disruptive change, things that are going to absolutely change our specialty massively. And I think I've seen some in these 2 days. Now, everybody here, when you think of disruptive change, you always think everything's going to be fine, everything's going to be the same. You know, things don't change that quickly. But the lessons of history are that things always change much faster than you think, and you've got to be prepared for disruptive change. Even 100 years ago, there was disruptive change. Just one block away from here, here's the photograph in 1900 of the automobile situation along that road. There were 99 horses and carts going along this road. And there's one little thing, something new is on the horizon. There's a guy with a car. And imagine being that driver in that car, shouting to all the horses, "Hey, you're all going to be history. You're all going out to the fields to pasture." Nobody's going to believe you, are they, in 1900? 13 years later, every single person was taking a car. Apart from one little person going, "It'll never catch on." So disruptive change happens, and it happens much faster than you think. But let's just consider for a moment how massive that was. From 11% to 81% in only 10 years. How massive was that? They had to invent a whole automobile industry, production lines, factories. They had to invent a second whole industry, filling up your car with petrol and supplying petrol. And they had to invent a third thing. They had to change all the roads from cobbles, so the poo all went to the sides, to tarmac that you could run on with little slick tyres. 3 industries changed, and they fought World War I at the same time. That was massive, fast, disruptive change. And that's what I mean by disruptive change. So horses to cars, CDs or LPs to MP3s, and then now downloads. And open aortic valve replacement to TAVI. Even in our modern era, we see these things. Let me just show you a few other little examples. The older ones amongst you will remember. I had a Nokia phone. This was 2007, Forbes magazine. Nokia, 1 billion customers. Can anyone catch the cell phone kings? That was the year the iPhone came out, 2007. Kodak. As a child, you remember going to get your films developed. In the year 2000, 14 billion of revenue, and yet 12 years later, they were bankrupt. 12 years. And here is actually a graph of disruptive change. You can take all the industries and put them on a graph. And what you see is that disruptive change is happening faster and faster. So when a fridge comes along, it takes 10 years to get into our houses, or some air travel. But now, when Uber, Spotify come along, when new apps come along, bam, in a couple of years, it goes from nothing to pure 100% penetration. Disruptive change happens fast because we're such a smaller world. We can see it on YouTube, and we can share our ideas. Here's a few predictions, and I will come back in 10 years' time, and you can tell me if I'm right or wrong. I'm going to be right. The next car you buy is going to be your last car. You don't believe me, but it's absolutely true. And it's 5 industries coming together to make this happen. Batteries, electric vehicles, autonomy, and Uber-type things and solar. They are transforming the way we're going to do travel. Already electric cars are crashing in price. There's a car called a Bayesian, that's $8,000. That's going to come out in 2021. They're crashing down in price. It's 10 times cheaper to fill up an electric car than a petrol car. You're mad to fill a car with petrol. There's only 18 moving cars. I only have to service my Tesla once every 4 years, compared to you guys going every 6 months. And the amazing thing is they last 1 million miles, not 200,000 miles. All these companies are working on autonomous vehicles, and you're all thinking it's not going to happen. But this is myself actually writing this presentation. I wrote it on the way to the airport. I was being driven in my own car. So it already exists. And actually, it's the regulatory framework which is stopping this going into production. So what happens if cars drive themselves? Well, just like Spotify, 5-10 years ago, you'd go and buy a CD. Now you just pay subscription. Films, I used to go to Blockbusters. Now you pay subscription. My phone's on subscription, so why shouldn't your car be on subscription? You phone in the morning, your Uber comes. Why would you pay $30,000 for a car? The answer is you won't. What's this going to do to the US, where your car production is going to go down 80%? We don't produce any cars in England, so I don't really care about this. We're a third world country. And so new vehicles crash. Petrol crashes. The price of petrol is going to absolutely crash. The Middle East becomes less important for production. Difficult ways of producing it, like off-sea, become uneconomic. Because solar is going to take over, Tesla already make panels that look like your own panels. Tesla have just produced a new system where you can put solar panels on your roof, and if you don't like them, they'll take them away. No contract, no time frame, no 3 years you have to have it. If you don't like them, take them away. But it's going to be cheaper than any other way of producing it. Now, if this happens, suddenly parking spots free up. Suddenly, billions are saved. And you know what? This is going to fix global warming as well. The UN should be here today, not over there. This is going to fix global warming. This is disruptive change. So this is one example of disruptive change. We are all going to change the way we transport. And I just want to show you this to the airport in my Uber electric car. So I think that might happen. Now, let's just think where we've been and where we are now. So Bob Safolio in 2009 was doing thoracotomies. You wouldn't think it talking to him now, would you? 9 years later, he's the world's greatest proponent of robotic surgery. That was just 9 years ago. That was a big change. We all learnt the amazing three-port VATS lobectomy. I learnt it from videos from René and Henrik and Scott and all the people in the audience there. But 7 years ago in the UK, it was 4% of our VATS lobectomies were by VATS. Now we're at 50, 60, 70%. We've actually had thoracic disruption. Here was the original graph from Copenhagen of total disruptive, quick, rapid change. And the rest of the world followed. We quickly all converted to VATS lobectomy. Diego came along and changed the world to uniportal lobectomy, but he didn't do it via writing papers. He did it the new way. He did it with YouTube. He did it with social media and Twitter and by interacting with people. So it now means you can change what people do surgically far quicker and far faster. And now there are all sorts of wacky, amazing approaches that you can go through the neck, you can go through subxiphoid, you can go through all sorts of strange and wacky ways. And this has all just come in the last few years. And you can even do these amazing things where you don't even prepare for a thoracotomy if you make a mistake, because you're just not going to make a mistake. I mean, these are truly mind-bogglingly only a few years ago. And, I'm trying to work towards things like surgeon-powered robotics. You get wristed instruments. You've got self-control of your camera. And, even that is an evolution of VATS lobectomy. These are all coming, and they're coming very rapidly. I haven't even talked about robotics. There's going to be an absolute flood of robots, and they're coming now. I've already showed you Versius, which is already here, and it's half the price of Intuitive. Revo have got a thing that looks suspiciously like the Intuitive, doesn't it? But it's half the price. Medtronic are coming out very soon with their own system, which will be half the price. Verb are going to do some amazing things with technology, with YouTube and with Hangouts, and they don't even call themselves a robotics company. Shanda's already used the single-port XI in thoracic surgery, and I believe there's a system in Hong Kong, and this is already in production and in use in other specialties. This will make many changes. I've shown you this system already. But is it the route that makes the difference? Well, I think we're going to transform massively to robotics, but actually, what have we seen in this conference? Well, Shanda and many others have shown us how to do the perfect segmentectomies. Now, Shanda called it segmentectomy for dummies, but I call it guess-free segmentectomy. How many of you have done the really horrible, I don't know where it is, I'm going to take it out, And then you're feeling it like that, aren't you? Going, please God, let it be in there. But this conference really has shown me the technology that means we can do guess-free segmentectomy, and that is a brilliant advance. But more disruptive than that, we were shown yesterday the amazing studies, the NLST trial, where this is the best screening trial in the, it's incredible the difference between other screening trials, 320 to save a life. And actually, in Europe, we've done that. We repeated it for some stupid reason. I don't know why, or we don't believe you or something, but it came out with just the same results. It absolutely saves lives. The blue box on the far left is the most important thing. With the brown, that's what we're doing right now today. And yet, if we had lung cancer screening, 50, 60, 70% of people would be curable from lung cancer. Imagine that, lung cancer being a curable disease. It really can be that for us, and that is amazing disruptive change. But the things we saw yesterday could be very disruptive. Kelvin and Dr. Sato and our colleagues in Canada were showing us navigational bronchoscopy, but they were showing navigational bronchoscopy and ablation. They were showing us that, you know, if we don't get into the bronchoscopy suite and we don't take this on as surgeons, you know, this is going to overtake us, because this is amazing. You know, if you've got a 1 centimeter tumor, let's say if you can get there, and if you can biopsy it, you can take all the markers, and if you can ablate it, you know, that is amazing. And if you can take all the N1 and N2 lymph nodes out as well by doing EBUS that we talked about yesterday, you know, you've got staging, you've got histology, and they walk out an hour later. And that was disruptive change in our specialty. We also heard that there were loads of different other companies coming to the market for this. Oris, I believe, was bought for $4 billion by Ethicon. So Ethicon have taken a big wad of $4 billion and they have bet that the future of lung cancer is this and not surgery. That is a big bet, but they're clever people. So I think this shows me that this might be the disruptive change. You know, we as surgeons have to take control of this, because that needs a general anesthetic. That needs good anatomical knowledge. That needs knowledge of N1 nodes, N2 nodes. That needs good knowledge of when this is the wrong thing to do and when it's the right thing to do. And we have to learn from cardiac surgeons on bypass grafts from PCA. It's not the way to do it, us or them. We've got to work together, because we know when surgery is better, we know when this is better, and when there's a combination that's better. ION as well. I think Shanda's group has used ION. Sir Folio's group has just used ION. This is a brand new way, by Intuitive. They're betting that this is going to be the future as well. Really, as surgeons, it's for us to take this into our operating room. And I've seen yesterday and today the way we do it, because we do it by using ICG. We want the ICG to do guess-free segmentectomies. Let's do it with navigational bronchoscopy. Let's start learning to take the biopsies. Then let's start trying to ablate it, but when you ablate it, take it out as a lobe and do the studies that prove it's ablated. Don't do the SBRT thing, which is, I'm just going to blow it to hell and they're all going to die in a year anyway because they're really ill. And look at my figures. We also were told, and I've got it on a slide, we were told the unbelievable results of the missile trial. If you haven't seen the missile trial, look it up. The missile trial was 40 patients in Canada. They did SBRT, then 12 weeks later, they did a lobectomy. In 40% of the lobectomies, there were viable lung cancer tissue. So SBRT does not kill all the cells. So we have to not make the mistake when we decide, let's use microwave, ablation, cryo in this field. And it's for us as surgeons that need to bring this to patients, because we have that balanced view. We even talked briefly about amazing things like this. This is Cellvisio. You can use optical microscopy. If you put this into your sample, it's a microscope in real tissue. You can see the alveoli, or you can see that's actually inflammatory cells, or you can see cancer cells. You don't even need to wait for the frozen. These actually exist. And so that, I think, is going to be the future. There are lots of other disruptive futures out there, and I don't know which is going to win. That last one is, we've got to get into it, but there is a huge explosion, as you know, of targeted therapies, immunotherapies. You know, it is exploding hugely. And, you know, induction treatment may become the treatment. We may only be operating on failures. I don't know, but it's out there and it will change fast. This is a huge industry and a very profitable industry. Will N2 surgery survive? Now, this is Valerie Rush's, the intergroup study on the left. That is the survival benefits graph from their study for N2 disease. And on the right is the Pacific trial, survival benefit when you add durvalumab. So no, we say, of course, N2 is gonna do really well and it's gonna carry on, surgery is gonna carry on. But actually there are physicians out there looking at that going, my patient would rather add durvalumab than an operation. And we're not making those decisions all the time, and it's adding extra treatments to chemoradiotherapy. So, and we may just be there for when they run out of 5th, 6th, and 7th line therapy. I don't know, but it might be. And then finally, there's proton beam. Now, proton beam is just SBRT, but because people invest $400 million in these machines, we've got to highlight the missile trial. We've got to do the trials with people. Okay, you do the proton beam, we'll take out the lobe, because we want to see if you're actually killing the cells or not. And Dr. Sanfilippo showed us that yesterday. So it really is a big era of change. We will never see faster change in these next 10 years. We are going to have our minds blown, but it's important for us to be at the forefront of this. So I'm very excited about the future, and I hope you'll join me in the future. So don't retire yet. It's going to be a quite hell of a ride. Thank you very much.
Thank you very much for this excellent, marvelous wrap-up. So I would like to invite Oizumi, who will be the host of the 3rd International Sublobar meeting in Tokyo, Japan next year.
I asked Joe if it's legal or illegal in the UK. So he told me no.
Somebody was put in jail for 3 months for getting into the passenger seat in the UK in a Tesla. So don't show anybody that video. Oh God, it's just gone out on CTSNet. Shit.
So congratulations on the accomplishment of this successful 2nd meeting. And I really appreciate the committee members for organizing this great conference. I'm Hiroyuki Oizumi from Yamagata University. I learned a lot of things, including novel technologies, operative techniques, results, and so on from this precious conference. This is, where's the touch screen? This is, you can see the yellow line. This is the shape of our prefecture. As you find, it looks like a profile of a handsome guy. So please remember our country. We are delighted to announce that the 3rd Sublobar Conference will be held on May 21st and 22nd next year in Tokyo, Japan. It will be held simultaneously with the annual meeting of the Japanese Association for Chest Surgery, JACS. In Asia, as you know, we have a lot of resources on sublobar resections, including subsolid nodules, management of surgical margin, spread through airspace, precise anatomical segmentectomy, reduced port surgery, and so on. And also we have the Jacob studies. So the time to visit Japan has come. We have a lot of scenic places, Japanese cuisine, including sushi, ramen, this is sukiyaki, everything. Please come visit our country. Also, the Olympic will be held in Tokyo next year. So this guy say, why not stay until the Olympic? Is it impossible? Then I will arrange you for you to live in Yamagata City. So anyway, again, thank you very much for this conference. And one more thing. Sandra requested Joel to perform the bronchodilator. However, we call it segmentectomy dance in Japanese. It's more easy. It's very easier to see the dance from the right side. So please see this is my student in the university. Volume, please. Speaker volume up, no? Okay.
これ右側ですか？左かあとはオプションだからまず右を選ぶ。
Again, I'll do that. So, how do you, space?
じゃあ第一着。まあいいや。とにかく行くぞ。はい、じゃあ行きますよ。上が1だから1、2、3、4、5、6、7、8、9、10。これは右側ですか？
This is the right
左
side.
かあとはオプションだからまず右を覚えること。取れましたか？はい。はい、いいですよ。じゃあ区域体操第一右側はい。1、2。
Thank you very much again. Thank you very much.
With that finish, I think there's a welcome reception down the exhibition hall. Thank you very much, everyone. Well done, great video, much better than mine. That was fun, hey.